Custom live streaming.
Custom live screening. And then that's it.
Okay, it looks like we are live. So Ms. Kayford, if you want to put yourself on mute, we should be all set to get started. Okay. Great. So good morning, everyone. Welcome to the Health Coverage Insurance and Financial Services Committee. We do have a series of public hearings this morning, followed by some work sessions this afternoon with a break in between. And we'll start this morning with introductions, starting with Representative Quint.
Hello, my name is Tracy Quint. I represent House District 144, which is 17 communities up in Aroostook County.
Thank you. Representative Arford.
Thank you, Madam Chair. Good morning. My name is Representative Poppy Arford. I represent District 49, which is the western part of Brunswick.
Representative Matheson.
Good morning. Thank you, Madam Chair. My name is Christy Matheson. I represent District 1, Kittery.
Representative Evans.
Thank you, Madam Chair. Good morning, everyone. I am Richard Evans. I represent District 120, including the towns of Atkinson, Brownville, Dover Foxcroft, Medford, Milo, Hornerville Township, and Lakeview Plantation. Thank you.
Representative Blyer.
Thank you, Madam Chair. Good morning, everyone. I'm Mark Blyer, and I represent District 22, and that is all of Leamington and part of Buxton, Standish, and Limerick.
Representative Brooks.
Good morning. My name is Heidi Brooks. I represent House District 61, which is part of Lewiston.
Representative Melrano.
Good morning. I'm Gina Melrano. I represent House District 62, which is part of Auburn.
Representative Morris.
Good morning. I'm Representative Joshua Morris. I represent House District 75, which is Turner, Leeds, and part of Livermore.
Senator Brenner.
Good morning. My name is Stacy Brenner. I represent Senate District 30, which includes all of Gorham, part of Buxton, and most of Scarborough, including the Scarborough Marsh.
And Representative Tepler.
Good morning. My name is Denise Tepler. I represent House District number 54, which is all of the town of Topsham, and serve as the House co-chair of the committee. I want to add that in this virtual environment, we are mostly at home. So things will occasionally happen in the background, and we'll ask your forbearance with that. The virtual environment unfortunately leads to this. So my phone may ring and I may turn off my video for a moment to make sure that it doesn't bother us any further. And various members may leave briefly for a variety of reasons, including attending other meetings of the legislature. So I just wanted to make that clear, and thanks to all the attendees and everyone on YouTube for paying attention to our committee meeting.
Thank you, Representative Tepler. My name is Heather Sanborn. I represent Senate District 28, which is half of Portland and half of Westbrook. And I see Senator Stewart as well. So we're gonna give Senator Stewart a chance to introduce himself before we turn to our first bill sponsor this morning. Go ahead.
Thank you very much, Madam Chair. Sorry, I'm a couple minutes late. Things rolled over in my other committee, and so just jumping from one Zoom box to another. I'm Trey Stewart, State Senator in District 2, which includes 51 communities in Aroostook and Penobscot counties, and I reside in Presque Isle.
Thank you, Senator Stewart. And we are, as always, assisted by Edna Kayford and Colleen McCarthy-Reed, our committee staff this morning, and we're glad to have their help. We will be hearing 3 bills today in the order of their LD numbers. So we'll start with LD 1776, a good patriotic bill number for Representative Roeder. So go ahead and present the bill for us.
Good morning. Thank you so much. And I have to say, as both a patriot and a musical theater fan, I'm very glad of my Bill's number. Thank you. Good morning, Senator Sanborn, Representative Tepler, and distinguished members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Amy Rader, and I represent House District 125, which includes a part of Bangor. I'm here today to introduce LD 1776, an act to allow pharmacists to dispense an emergency supply of chronic maintenance drugs. This bill holds great significance to me. I live with asthma and I depend on my inhaler to assist during emergency episodes. If you too live with asthma, you understand the overwhelming fear of not being able to breathe properly and being out of reach of your inhaler or having that inhaler run out. Once I was in the middle of an active asthma episode and I was denied an emergency prescription. My doctor said I should come in and see him before I was able to get a new prescription for my inhaler. This instance, along with multiple stories I've heard from my constituents struggling to get emergency supplies of their medications, was more than enough for me to research existing gaps in Maine law and seek a solution. LD 1776 allows pharmacists to dispense an emergency supply of chronic maintenance medications to a patient without a prescription if authorization is unavailable, so long as the pharmacist has a record of a past prescription for that patient. This legislation also requires insurance companies to provide coverage of the emergency supply. Controlled substances such as opioids are not included in this legislation. I urge you to support LD 1776, and I'm happy to answer your questions. So thank you for your time and consideration.
Thank you very much, Representative Rader. I've clearly been in my other committee too long with myself on mute. Are there questions for the bill's sponsor, Representative Tepler?
Thank you very much, Madam Chair, and thank you for bringing this bill forward, Representative Rader. I actually was asked by the gentleman for whom we sponsored the insulin emergency supply about this sort of approach. So it's interesting to me. I'm curious what the definition of chronic maintenance medications is and what conditions that might apply to. Does it apply to say type 2 diabetes medications? Does it apply to levothyroxine for hypothyroidism? I'm just curious what you have defined in this bill for us.
Sure. Actually, there was a proposed amendment that a representative of various pharmacists across the state had brought forward to me that makes a lot of sense to me, because what I have in my bill right now has a shall instead of a may, which indicates that the board would have to have a rulemaking meeting to designate all of those. The pharmacist representative made a very great point that if we put in may, the pharmacists themselves have a pretty good idea of those maintenance medications. So they might be able to look at someone who they know and have dispensed medication before and say, yes, you have high blood pressure and this medication, you need an emergency supply of it to get through until you can see your doctor. So we haven't specified all of them. We just want to make sure that we're excluding the controlled substances like opioids.
Okay, so if we retain the shall instead of the may, then the pharmacy board will create the limits on the dispensing. And if we put in may, each pharmacist individually will make that decision for themselves?
That is my understanding, yes. And one of the reasons that the may was suggested instead of the shall is that if shall is in place, then the rulemaking has to take place, and it will take 6 months to a year to goodness knows how long to actually get that into reality.
Unfortunately, that does seem to be true with some of our licensing boards. Thank you.
Thank you.
Representative Brooks.
Yes, thank you very much, Representative Broder, for bringing this extremely important issue that's close to my heart and close to, I'm sure, a lot more people's hearts and minds, either having something like asthma, where it's literally really difficult to change, catch your breath. And having asthma myself, and having always, fortunately, before I was diagnosed, and having over-the-counter medicines, perhaps for treatment, having an inhaler, having a rescue inhaler, and that's really critical. And I have met people that have needed to literally go to extremes to try to get one more puff out of their inhaler. In extremes, I mean extremes. So the affordability is really important to me. The access is really important. I live in Lewiston, and in Lewiston we have two major hospitals. We have a lot of providers compared to a lot of the rural areas to islands. Right now, going to a pharmacy is a challenge, not just because of the ice storm or because of the weather in Maine, but with the coronavirus, we might want to step back. So this isn't just a commentary on how great I think this bill is, which I do. But I think that increased access, like 90-day supplies versus 30-day supplies, and with our interplay of medication, the more I've learned about it, the more challenging it seems, just as far as some people are incentivized to get a 90-day supply, and the pharmacies may be incentivized only to fill 30-day supplies. And I think asthma is a perfect example. Like for me, my thyroid's out. So if I do without levothyroxine, that's not tenable really. And something like calcium. Some things some people are important for. So I know there's a compromise and there's a way to find that middle ground, but I appreciate your strong support of this and bringing it to our attention.
And you raised a good point, though, that sometimes going without medication can be a stress on the healthcare system. So, for example, one time I was without an inhaler, I was having an asthma episode. There was no way to control it without medication. I wound up in the ER. That was a huge expense. And, if we have a lot of people who are accessing emergency services just because they can't get their prescription, that's not good, especially now.
Senator Brenner.
Thank you, Madam Chair, and thank you, Representative Rader, for bringing this bill forward. From the perspective of a state that has a lot of rural communities, it seems like this would be relatively beneficial in terms of expanding the kinds of access folks would have when it's much more challenging to get the transportation you need to a care provider appointment in order to get your prescription renewed. Can you talk a little bit about whether this has been implemented in other states and whether it's had an effect on access in rural communities?
I haven't necessarily had a focus on rural communities, but it has been implemented. I was looking specifically for wording at David's Law, which is focused inherently on insulin. So as to the expansion, it has been, it's been implemented in a handful of other states. I can get you that information for the work session. But one of the reasons I wanted to bring it forward was because of our relative ruralness and the fact that it is difficult for people to get in to see their provider. I come from a town that doesn't even have a stoplight. So I understand the challenges of having to get back and forth for provider appointments and even accessibility to a pharmacy, because the nearest pharmacy to my town after the drugstore closed down was a 30-minute drive away.
Okay. Seeing no further questions for the bill's sponsor, we thank you for joining us today, and I am going to return you to the attendee space as is our practice in this committee. And we will next hear from those who wish to speak in favor of the bill. And I am going to start with Hillary Koch. Good morning. Please go ahead.
Good morning, Senator Sanborn, Representative Tepler, and distinguished members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Hillary Koch, and I live in Waterville. I've used a rescue inhaler for several years. My needs are thankfully not life-threatening, but when I really need my inhaler, my breathing is incredibly labored and I must stop all physical activities. A few years ago, I received a letter that my primary care physician was leaving the practice and I would be assigned a new provider. After calling my pharmacy to refill my inhaler, I received a call from my doctor's office telling me that my prescription had expired and would not be renewed because I needed to have an annual physical exam. When I explained that I had been into the office for a physical exam within the last 7 months and had seen my previous PCP, whomever I spoke with apologized and admitted that they had made an error and that my prescription would indeed be refilled. After I got off the phone, I found myself a little bit frustrated. My history was clearly noted in my records that I'd been using my inhaler regularly for years, and that a rescue inhaler by design needed to be used for a chronic condition that should never be withheld for an appointment. This interaction led me to think about my 15-year-old son, who some of you have met before. My son has type 1 diabetes, an autoimmune disease, and he is insulin dependent and will die within days without insulin. My primary job for 13 years has been to be his pancreas, but now I'm slowly transitioning that job to my son. And as he gradually gains independence, we've learned that he also suffers from another very common condition known as teen brain. Millions of teens suffer from teen brain all over the world, and managing a life-threatening disease with it, as you might imagine, is a beast. And while my son rocks it on most days, there are others when he doesn't, and it made me wonder about what might happen if he goes off to college with his teen brain and forgets to schedule or has to reschedule an appointment with his endocrinologist. You might be appalled to hear of endocrinologists who have indeed withheld insulin prescriptions. And I know of people who've actually had to wait months to get appointments and therefore have needed to ration insulin and rely on the black market, truly risking their lives. I fell through the cracks when my PCP left the practice, but I was fine. Patients who have life-threatening diseases do not have the luxury of time to wait. So I beg you to not sit there in judgment and ask why someone's prescription hasn't been renewed by a doctor. The question here is not why the prescription has lapsed, but what is the value in having a pharmacist fill it? Simply, a pharmacist dispensing it could save lives. LD 1776 fills a very practical gap when we find in our medical system, one that pharmacists are indeed trained to do. A pharmacist can easily identify and dispense the most recent prescription on file, filling life-saving medications like insulin, glucagon, EpiPens, and relieving an overburdened medical workforce. This also addresses situations like people who are in between jobs, those without or in between primary care physicians, or even health insurance. And it also begins to touch on racial and social justice issues, since we know BIPOC communities have less access to quality and consistent medical care, and therefore are less likely to have routine visits to doctors. So I ask you to please support LD 1776. Thank you.
Thank you very much. Are there questions? All right, seeing none, we thank you for joining us today. Nice to see you.
Nice to see you.
And next we'll hear from Matthew Marston.
Senator Sanborn, Representative Tepler, and members of the Health Coverage and Financial Services Committee. My name's Matt Marston. I'm a resident of Hamden and a vice president of pharmacy and a board member of the Maine Society of Health System Pharmacists. Today, I'm submitting testimony on behalf of the Maine Society of Health System Pharmacists, an organization that has more than 300 members statewide and primarily represents individual pharmacists, technicians, and students who practice in the health system setting. I am today testifying in support of LD 1776. Even before the presentation of this bill, pharmacists have long served as advocates for our patients and assisted with the coordination of timely and accurate receipt of their medications. Pharmacists all over the state of Maine could provide numerous accounts of patients running out of their medications, looking for refills when none remain on their prescriptions. Many pharmacists have made accommodations for patients to loan a few tablets to patients in need, or take them out of their next prescription to bridge them until a refill arrives. While this has been a longstanding practice out of necessity to address the patient access issues that LD 1776 seeks to resolve, this leaves pharmacists in a position where they're putting their own license at risk to prevent potential harm from coming to their patients. While MSHP supports the intent of this bill to prevent harm and interruptions in medication therapy, it is imperative that the following key elements are addressed either through legislation or rulemaking. One, chronic long-term conditions are undefined in this bill, which leaves very broad discretion to the pharmacist. Renewing of a prescription without a provider's review is not appropriate for all conditions. For example, a patient receiving oral chemotherapy must frequently undergo intensive lab monitoring and dose adjustment prior to renewal of their prescriptions to make sure they're on the appropriate dose. Or a patient receiving anticoagulation with a drug like warfarin requires monitoring of their INR to stay in therapeutic range and prevent either clotting or bleeding based off the dose that they're receiving. Numerous other examples exist. What is considered an emergency supply must be defined. MSHP would advocate for defining this as the minimum necessary quantity required to provide treatment until a prescription from the patient's practitioner may be obtained. Consideration of the number of times in which a patient may receive an emergency supply with a given time frame is also necessary. Frequent utilization of this pathway to obtain medication could highlight larger deficiencies in the patient's overall care, which really do need to be addressed. And fourth, insurance providers frequently do not recognize pharmacists as prescribers for claims that are submitted, which could result in potentially significant out-of-pocket expenses due to lack of coverage. So I think making it explicit that this would be under the prescribing authority of the original prescription would be beneficial to add clarity. And lastly, I would add that if the above is addressed through legislation rather than rulemaking, the Maine Board of Pharmacy will be unable to alter these definitions without going back through legislature. The landscape of pharmacy changes rapidly, and inclusions or exclusions to the medications or conditions that this bill will apply to should remain flexible as well. Thank you.
Thank you, Mr. Marston, for joining us today. Are there questions? Representative Brooks.
Thank you very much, Mr. Marsden, and thank you for your supporting the general concept behind the bill. I had a friend's grandmother, and I'm not making this up, but that was cutting her Coumadin in half because she didn't want to tell her family she couldn't afford the co-pays anymore. It's just heartbreaking. So I do appreciate the interplay, and I know it's really intricate, the interaction between a provider, a pharmacy, and insurance and the patient. So I do appreciate your support of the bill. Some of the things are things that we're moving along with during a pandemic and changing circumstances, and in the interplay of like the pharmacist is doing more as far as frequent vaccination, frequent like over-the-counter management as well. If somebody came, whether they're a new patient or not, somebody could come with a Tylenol or a Mucinex and say, this is what I'm on, and does this interact, and should I take this in addition to the such and such medicine? That's part of the pharmacy's role, although a lot of people don't take advantage of it. So I do appreciate the sentiment, and I do hope to work with people more on this legislation. And the critical thing is saving lives and helping the community, really. So I do appreciate your stance that this is important. I can understand some insurance pressures, especially with some medicines.
Representative Brooks,
Go ahead.
do you have a
The question?
question?
Question: How can we ease the insurance paperwork or computer paperwork to help make it more user friendly?
Sure. So the patient would have already been receiving a prescription under their primary care provider or specialist. So if the bill spelled it out that the emergency prescription would be under the auspice of the original prescription, so processing the claim under the original provider of that prescription versus the pharmacist themselves, I think it would cut through some of those barriers from a claim standpoint. Many insurances still don't recognize pharmacists as providers, although most recently in here in Maine, that has been changed with state legislature to recognize us as providers. Not all insurances have adopted that. So to get the most coverage, making sure that that prescription is processed under the original provider would follow that pathway.
Representative Tepler.
Thank you, Madam Chair. And I'm dealing with this concept of original provider, and because I don't think what we want in terms of wording is original provider. I think we want provider of most recently expired prescription, because the original provider, for example, of some of the medications I've been on is not my current prescriber. So I guess I'm wondering, thinking about that wordsmithing, is there a time period in which one that most recently expired prescription would need to be? So if it's a year old, is that okay? If it's 6 months old, is that okay? That's sort of part of what I'm thinking out in terms of what we need to wordsmith here.
I would agree. I think what the bill is intending is really somebody avoiding interruption in care. So if a medication was filled, I would say more than even 120 days ago, since most are either 90 or 30 days, it's probably an old, outdated prescription. So I do think putting some timeframes in there would be beneficial, and what prescription would be appropriate to be filled in an emergency setting.
Thank you.
Mr. Marston, my question, as we balance the concerns here around patient safety versus what we want to put in the statute versus what we want to do in rulemaking, is that it strikes me that the strongest rationale for this bill, and one that I even find in Mr. Morin's testimony from the Maine Medical Association, which opposes the bill, is that pharmacists are already doing this. And they're doing it as a matter sort of patient safety and of their own sort of moral imperative. But it's not legal, and it is technically a violation of their license. We also have written testimony, a letter from Ms. Betts from the Board of Pharmacy, asking us not to require rulemaking prior to having this statute go into effect, because that would delay the effective date of the statute by a lot. And based on some other communications with the Board of Pharmacy, we know that we've put a lot on their plate, plus vaccinations and everything else. And so they are very backed up in terms of their rulemaking process. So I guess my question to you as a pharmacist and as someone who is speaking on behalf of a group of pharmacists, is that some of your suggestions are that we need to tighten up the language of the law, but that we should do it in rulemaking. And I guess my question, particularly looking at the first one about definitions, I have the sense that pharmacists are well trained to determine the difference between an oral chemotherapy that they probably should not give you an emergency dose of, and a blood pressure medication that they should, or a rescue inhaler or an EpiPen or whatever it might be. And that the issues where it's close to the line, or where they don't understand why you would be asking for a pill, or maybe the patient is confused, that's why we have professional pharmacists, and that their training would put them in good stead to make those determinations. And that then the board could come in at some point in the future, if they needed to, with permissive rulemaking, and clarify things further if there were some repeating concerns in that regard. So I'm wondering if you could comment on that issue of professional judgment, and whether some of that could be used in place here of rulemaking.
Yeah, I agree with you. I think that professional judgment is something that pharmacists use all the time, and we are trained as medication experts. That is our profession and our calling, and being able to recognize the appropriateness of filling an emergency medication is certainly within the purview of our training. and our scope as pharmacists. So I would say not waiting for rulemaking would be appropriate to determine what the inclusions or exclusions are. But I would encourage the Maine Board of Pharmacy to take it up and put forward some definitions there, just because a lot of the opposition that I've seen out there towards this bill is surrounding not having that defined. So I think addressing that through rulemaking at a later date would be appropriate. And I certainly don't have any immediate concerns about a pharmacist's ability to place that judgment in that individual patient scenario either. And I think really at the heart of this, Senator Sanborn, you called this out, is that right now pharmacists are having to do this and put their license forward to do something that is inherently not lawful in the state of Maine. But we care deeply for our patients, and we don't want to see anybody put in an adverse medical situation due to lack of access to their medications. So it really tugs at both our duty to serve our patients as well as our duty to uphold the laws in the state of Maine. And this bill, I think, does address that.
Thank you. That's helpful. Are there additional questions? Representative Quinn.
Yes, thank you. I'm just thinking back to the insulin bill. When insulin was dispersed, the provider would be notified. And in a situation like this, we're talking about someone who may not have been to see a doctor in over a year, and they're assuming that that's what the problem is when something else could be going on. Like, I'm all for, giving that emergency supply. I'm just a little concerned that something can be missed in with that. And I didn't know if there were some sort of parameters or a stop guard or where can we make sure that we're providing safety in that area? Because as I can't remember her name, but the lady that was speaking earlier, if you haven't been to the doctor in over a year, something else could have really gone on. It might not be asthma, it could be lung cancer. So I just wanted to make sure that question was out there. And that it's being, looked at as well. Would it just be a one-time thing? And then in order for them to get, say, another inhaler, I'm just picking on that one category, but you're looking at it in the other areas as well. If you're looking with cardiac medications, the same sort of thing, something could have changed. So I just have a little bit of concern there.
Yeah, and I've struggled with this one too. I did see one testimony that was submitted and put forward to limit it to a one-time up to 30-day fill, which I think is reasonable. I think some of the wording that I put out there too about minimum necessary quantity to get the patient through to their next provider visit, I think that allows some flexibility where, we're providing enough to get the patient through to when we think they can get in to see their provider. Pharmacists follow up with providers all the time, right? So this would prompt a phone call to that provider, and likely the pharmacy has already reached out and requested a refill from the provider already as well. So I think there's going to have to be that back and forth to make sure that that authorization does come through from the provider, and also make sure that that patient is seen by the provider in a follow-up visit, which really needs to occur for continuity of care.
Representative Arford.
Thank you so much for being with us today, Mr. Marson. And I understand the need for this bill, and I thank Representative Broder for bringing it forward. I myself have been on a chronic maintenance medication for over 40 years. So I've experienced personally many instances that we've already discussed about and some that we haven't, where I have had difficulty getting the prescription filled in a timely manner. And this is the one thing we have yet to discuss, and I just want to know how this would be handled by the pharmacist. My medication, I have to have blood tests done in between when one prescription is written for 6 months, and then 6 months later, I need a new prescription. And in between then, I need to have my levels done that test whether or not I'm actually on the appropriate dose in that prescription. And so my provider will not write me another prescription until I've had those tests done, which is protecting me, protecting them, protecting everybody. And sometimes over the last 40 years, I have lapsed in getting the proper tests done. And so it's been very difficult, and I've had to work it through. I know I'm not the only one in that situation. So how would this work if, in fact, the emergency need was based on the fact that the testing that needed to be done between when the prescription was written and now we're needing this emergency dose, that testing has not been done. So in fact, it's not a for sure thing that the correct dose is going to be prescribed. How would you even know, or how would you handle something like that?
Yeah, I think the root of this too is the education that pharmacists receive about the medications, and it's very individualized. It's individualized to the patient, the medication that they're receiving, the monitoring that's required, which labs are required, what is the relative risk between stopping abruptly the medication versus not taking or stopping abruptly the medication until you can get that lab versus taking the medication until you get the lab, because more often than not, abruptly stopping the medication is actually more harmful than awaiting those lab results and making that dose adjustment. But I did share in the testimony too, that's not always the case. Some things like chemotherapy drugs, you could actually create more harm by not having those lab values at the time where the individual is supposed to receive that medication. So there is a lot that needs to be defined, as I included in my testimony, but largely, if you're looking at 98% plus of cases, the pharmacist will be able to accurately make that determination of what's safe for the patient and dispense an emergency supply if appropriate.
Thank you.
All right, seeing no additional questions, we really thank you for your testimony and expertise today. I'm going to return you to the attendee room. And next, we will hear from Nathan Williams. The Zoom room is a little bit not very quick today. Let me try that again. Here it comes. Okay. Good morning. Go ahead.
Thank you. Senator Sanborn, Representative Tepler, members of the committee, and I wanted to thank Representative Rader for sponsoring this bill. I brought some visual aids today. I'm a type 1 diabetic, and I have been for over 30 years. I take injections of 2 types of insulin every day. One is Lantus, which is a long-acting kind of a base insulin. I take a set amount of this every night. And this is not so much an issue because it's a set amount and you can calculate exactly how much I'm going to need for a 30-day supply, for example. The other type of insulin I take is Humalog, which is a quicker acting insulin that I take with every meal. And it's based on a sliding scale. I also take it in between meals if my blood sugar gets too high. And this is a constant measuring and balancing act I have to do. And because it's a sliding scale, I never know how much I'm going to need for any meal. And it's impossible to calculate how much I'm going to need for lunch today, let alone how much I'm going to need to last me for a week or 30 days or 90 days. And there's a situation where I have a valid prescription, and the prescription is written with a rough estimate of 15 units for breakfast, 24 for lunch, 30 for dinner, for example. But that it doesn't always take into account any extra dosages I might need to account for high blood sugar, which may be based on a miscalculation of what I had to eat. Maybe I wasn't able to exercise as much that day. Maybe I had extra stress that day. There's a variety of factors that go into your blood sugar level. And so it doesn't account for that. And so there are circumstances where, because insulin is dispensed in either a 30-day or a 90-day supply at a time, I run out before my supply is calculated to last. And so when I go to refill it, I'm told that even though I have a valid prescription, even though I have refills remaining, insurance will not cover it because there's still time remaining. And so it's as if I don't have a valid prescription, and I'm told I need to go get another prescription with different dosages in order to get it covered. Or I have to call the health insurance company. And if anyone's tried to navigate the phone maze of a health insurance company and get someone to actually understand what's going on, that I actually need this medicine now, and they should cover it because I do have refills remaining. Sometimes that works, sometimes that doesn't. Sometimes, if it's only a day or so, I can maybe make adjustments to stretch my supply to last that long, but sometimes it's a week or more that something has to happen. So my other options are to go without, which is not a good option and can lead to long-term health issues. I can go to the hospital, which is probably what would happen if I went without anyway. And in a pandemic that's taking up hospital space from people who truly need it because of the pandemic, or I could pay out of pocket when a $30 prescription would cost roughly $1,500. And so it's my hope that this bill will address situations like mine, either in rulemaking or with this, because it's almost as if I don't have a valid prescription in situations like this, because they say the prescription that I do have, it should have lasted me when clearly it does not.
Representative Tepler. Oh, I'm sorry, Mr. Williams. I thought you were done.
Oh, sure. That's fine. So I urge you to pass this, and I'm happy to take any questions. Thank you.
Thank you. I apologize for interrupting. Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you so much for being here, Mr. Williams. I completely understand the problem and your concern. I'm just curious, because of the limitations of our ability to regulate, who your insurance is through. Is it employer-based insurance? Is it a marketplace-based insurance? Because whether or not we can potentially regulate this issue depends on that. We only have the ability to regulate the individual market and the small group market. We can rarely regulate employer-based for larger group markets because of the federal ERISA law that preempts our ability to regulate.
Mine is an employer-based, but even if you can't fix it for me, if you can fix it for other people, I think that's definitely worthwhile.
Yeah, I agree. I think we should make sure that that is okay. I just wanted to share with you that we have limitations in our ability to regulate.
I understand.
Okay, are there any additional questions? Representative Brooks.
Yes, thank you, Mr. Williams, for being here, for that clear explanation of the struggles that you are encountering, both with the diabetes and with the navigation of our current situation. So my questions are a couple-fold. One is, can you tell me a little about your testing supplies and other things? Like, do you go through insurance for that, or does that cause difficulty if you, say, use more test strips because Lancets because your sugars are very variable or anything like that? Like if you happen to go through more of those, you're symptomatic, how does that coverage work for you?
Well, it's not ideal. I'll be honest with you. I use a continuous glucose monitor, which is a little device. It's about the size of a quarter that attaches to my arm. And I just tap my smartphone to it and it tells me what my blood sugar is. And it can track it over time and show trends and everything like that. And so in terms of testing supplies, the only supply I need are those, little things to stick on my arm. And they last about 2 weeks at a time. They are not covered, at the same rate as other testing supplies are. A 90-day supply will run about $100 for those. When you test more frequently with the finger sticks, yeah, that can run into problems with, getting enough of those. And not everyone can have the continuous glucose monitor. And I can't even get the type of glucose monitor I would prefer to have. There's a couple of different types. One doesn't require you to manually tap it. It just automatically updates to your smartphone or to the reader. But my insurance will not cover that at all. And that would be like $300 for every month. And that's just, beyond, that's cost prohibitive. This one is at least somewhat better. And so the best care is the continuous glucose monitor. But with the finger sticks and trying to get all the testing supplies, that can be quite expensive as well. Because it's not just the test strips, it's the lancets, it's making sure you have a reader, making sure you are keeping track of everything that's going on with that, and you're keeping an accurate log. And so making sure your insurance company covers all those. Some insurance companies will provide you with a free monitor, and that's great, but that doesn't cover the ongoing supplies of the lancets and the testing strips to go with it.
Okay, thank you. I want to make sure we stay focused on the subject of this bill, which is about pharmacists. Are there any other questions? Seeing none, we thank you for being here with us, Mr. Williams, and for the additional testimony. Are there any additional folks in our meeting who wish to provide testimony in favor of the bill at this time? Please raise your electronic hand. All right, seeing no hands go up, I am going to shift to those who wish to testify in opposition to the bill. I'm going to bring over Dan Morin from the Maine Medical Association. Good morning, Mr. Morin. Go ahead.
Hello, you can hear me, I assume?
We can.
All right, thank you. Sorry for the light above my head. I'm not in church. All right, thank you for allowing us to testify to LD 1776. We oppose it as introduced. I'm Dan Morin, Director of Communications and Government Affairs. I live in Gorham, and I work for the Maine Medical Association, which is the state's largest professional physician organization, representing over 4,000 physicians, residents, and medical students across all clinical specialties, organizations, and practice settings. I won't read my testimony. I do want to address a few points that were made previously in testimony, specifically Representative Rader and Ms. Koch's examples. They seem to be anecdotes seemingly presented to have this bill be an attempt to override the prescribing clinicians in question and look to circumvent a lack of statutory authority for pharmacists to prescribe. Many examples were given by Ms. Koch that seem to be outside the process outlined in the bill that cover existing prescriptions for chronic conditions and maintenance. There were comments made about difficulty seeing providers. The bill again covers chronic medications, which should be under an existing and established patient-clinician relationship. Refills can be ordered by phone, and in many cases, periodic visits that were discussed, usually annually for follow-ups and review of progress, are widely considered appropriate standard of care. Representative Arford pointed out testing requests from prescribing clinicians. Mr. Marston even identified how care is very individualized. So this seems to be a one-size-fits-all bill, and based on the presentations in support, seem to be anecdotes attempting to override prescribing clinicians. As far as rulemaking, we believe that joint rulemaking ought to be in order. If it is put into the bill, the pharmacy board does not regulate or oversee licensees with the authority to prescribe under Maine law. While advocates claim that such actions are within the scope of pharmacy, they are not under Maine state law outside of naloxone, certain immunizations, and certain subcutaneous drugs. The choice of an individual drug for a particular patient is one of the most important clinical decisions in office-based medical practice, perhaps more than any other clinical judgment. And the physician's prescribing decision for chronic medications is the result of detailed information from a patient-physician relationship in drafting a long-term treatment plan. So in our testimony, you'll see the summary of our testimony. What is the documented problem to be solved outside of the anecdotes presented today? I remember hearing a testifier, and I forgot who it was years ago, say, quote, anecdotes are not data. The emergency supply should be defined in statute and be very short term. I've given examples in many states that have such laws that you are considering today. They are limited to 72 hours. The process in pharmacy and pharmacist requirements need to be much more clearly defined, and we should better define and broaden the drug type restrictions. For example, as far as the first, what's the problem to be solved? As Senator Sanborn indicated, we understand there's existing leeway for pharmacists to give a short supply. If it's not allowed and there's a threat on license and there's no statute or rule allowing short but necessary supplies to be dispensed, have there been documented complaints filed with the Board of Pharmacy? If so, has the board taken disciplinary action against the licensee for dispensing a bridge supply of medication? This mile marker was used last year on a nurse practitioner bill when the nursing board was called to ask if there had been complaints, and the absence of complaints were seen by some supporters of that bill to mean that we should move forward with the bill. The emergency supply, as far as 72 hours, I keep hearing 30 days. I mean, if there's a problem about reaching your prescriber, including a physician, which are our members, there ought to be complaints filed with the Board of Licensure or the Board of Osteopathic Medicine. We would support that. We don't want any of our members not getting back to patients in due time, specifically within 72 hours because of a lack of necessary chronic maintenance medications. 30 days is not acceptable to our legislative committee if it's included in this bill. It should be 72 hours, and there could be stipulations made to allow for longer emergency refills in the event of a declared public health emergency like we've experienced recently. Pharmacists should be required in statute to notify the clinician authorized to prescribe by Maine state law of the emergency dispensing within a reasonable time, define reasonable time. We think this is especially important. Written documentation should be signed by the patient at the pharmacist with the pharmacy, informing the patient or the patient's representative at the time of dispensing that the short-term refill is being provided without the prescriber's authorization, and that prescriber authorization was required for any future refill. The drug type restrictions, I understand there's an exclusion for opioids, but other states that do this include all Schedule II substances. And our psychiatrists expressed concern that benzodiazepines, Schedule IV, ought to be included because there's a genuine problem with misuse in the community for that. Thank you for considering our comments and recommendations, and will be available during the work session if necessary, and willing to provide any information between now and then to the committee.
Thank you, Mr. Moran. Mr. Moran, my question is with regard to your written testimony, which suggests that that there is right now the practice that we've discussed with others who've testified before you of pharmacists dispensing bridge medications for which no valid prescription exists. And your testimony seems to indicate that you acknowledge that that is not strictly legal, but that we shouldn't do anything about it because there haven't yet been any enforcement actions about it. And that seems like an odd rationale for us not fixing this area of the law to give some certainty and clarity. So can you speak to why we should just allow this to live in the gray space of the Board of Pharmacy not taking regulatory action or licensing action against individual pharmacists, rather than giving some clear definition to when the practice is appropriate?
Thanks for the question. If my testimony wasn't clear, we're certainly not saying that, if there's no problem, no complaints, don't do it. I've taken advantage of that myself at my local pharmacy because I'm awful at compliance. I receive, 2-3 day supplies of some of the medications I have in order to give me time to contact my prescriber on Monday, but that's on me. And I contacted my prescriber and that was solved. So we're certainly not saying that the committee shouldn't do anything. We're saying we're aware that it exists. We understood that it may be allowed, but apparently it isn't. And the reason for the bill, according to the testimony I read, seems to be we're putting our licenses in jeopardy. Have there been complaints? Have there been issues? Or have there been pharmacists who have been disciplined on this? That's one of the factors to consider. That's separate and apart from the fact that in our testimony, we say there should be allowed. And if there is a problem here and there is a gray area, let's fix it, but let's define it and let's put some pretty tight guardrails on it. Because what I'm hearing today is as I'll reiterate, simply anecdotes from both of the proponents that started this that were upset with their clinicians, and they want a pharmacist to be able to override their disappointment.
Okay. That's
You know, Madam Chair, I see.
not how I would characterize.
Well,
what
I
we
see heads.
heard.
I see heads nodding, but the representative came up and said she tried to contact her prescriber, and the prescriber said that they wanted her to come in, and she didn't feel she needed to do that. So she was proposing this bill because she was worried and distressed, as I'm certainly understand. So in that specific anecdote, like the sponsor gave up, she was upset that the prescriber wanted her to come in. So she wanted this bill introduced to solve that problem so a pharmacist could override that decision. We can go back and look at the tape. I'll be happy to. These are all recorded now.
Mr. Moore, the issue I'm having and the skepticism I have is that you just gave an example, anecdotal though it may be, of your own issue over a weekend.
Yep.
That would have been solved very squarely by this bill.
Yeah, absolutely.
And it is within the four corners of this bill. And I guess I'll just leave it there.
You can drive a truck through this bill, though. There's no stipulation on what medication it is. There's no time limitation.
Sure.
There's so many holes in this bill. We are opposed. If you see the top of my testimony says opposed as written, we would be happy to work to fill that gray area, to put appropriate guardrails up there so we're not overriding licensed practitioners who are authorized to prescribe in Maine and giving that ability to people who don't have that under their current scope to override the decisions made by lawful prescribers.
Okay, that's helpful. I think what I was responding to was the implication, at least as I read your testimony, that there was no problem to be solved. And if that's not your testimony,
no, not at all.
Then I appreciate that, and we can tighten up the bill. So thank you for that clarification. Representative Tepler.
I think Representative Brooks had her hand up before me, so I'll yield my time to her.
I have more things for thanks, Chair Tepler, and Chair Sanborn as well. So I have questions for the work session. Some things that came to my mind as you were giving the testimony. One was that helpful suggestion that there be more of a kind of an expedited process through the pharmacy to a provider to be reevaluated medically in these conditions. So I've found, and I'm in Lewiston, Auburn again, we have two healthcare systems, a lot of doctors, but there's a healthcare shortage, as you know, even before the pandemic. For somebody that doesn't have a primary care provider or any provider, whether it's insurance reasons, they're too busy working, they don't have the appropriate, because they're, for whatever reason, we have a provider challenge for people that don't have that access. That's not just anecdotal. I know that for truth. And it's variable. And then with the pandemic, let's say somebody goes to work and they are, before the pandemic or with the pandemic, they're not feeling well, or they call in to say they don't feel well. And the employer says, I need a medical note. So maybe the person has insurance, maybe they don't, but if they go to an urgent care because they don't have a provider to get a medical note, that's a barrier. That's a financial barrier too. I've heard of people that have gone to a pharmacy, and when they are hit with a $2,000 bill, they have to buy just a few pills at a time. So it's really more of a challenge than I think we're giving credit to. But your scope of practice issue is well taken. Like, medical professionals are trained as medical professionals. Pharmacists are multitasking in a lot of things with a very brief visit. They don't have necessarily the expertise or the time with the patient to come to that physician patient or provider patient decision for medicine. So it is an issue that I do think we need to work on. And like I said, I think you had some good points, but I think it's more than an anecdotal problem.
Can I respond, Madam Chair?
Please.
But the issue here, Representative Brooks, I completely agree with you about problems to access, and the MMA advocates for bills that increase access. But that's apart and separate from this bill before us. This bill before us outlines existing prescriptions for chronic maintenance drugs. This isn't about people not having access to primary care providers or not being able to get medications because they can't afford it or they're not covered. This bill specifically talks about existing prescriptions that are done through defined patient prescriber relationships that are part of a regimen and treatment plan for chronic maintenance drugs. The issues that you brought up should be addressed, but they're not within the parameters of this bill.
Representative Tepler.
Thank you, Madam Chair, and thanks for being here, Mr. Moore. And I guess one of the things that is coming to me as we discuss this is the overall changes in medicine that have been occurring over a period of time, and that the treatment of patients is no longer the sole purview of physicians. This may or may not be good. I'm not evaluating that. That is, it seems to be driven in part by cost control issues on the part of insurers, but it's also driven in part by the fact that we can't seem to build enough of a community of physicians, particularly in rural areas, to serve the needs of the public. So here we have a situation in which we are thinking about a small expansion in the role of pharmacists in filling a gap. And I guess I understand completely the need to set parameters around this. But I also feel that your comments about anecdote are concerning, because I mean, if we need to have data to prove that that gap exists for a lot of patients, I think we can probably acquire it. But I'm a little surprised at your doubt at that gap, and wondering about whether or not this is in part about the changing role of physicians in the world today.
Can I respond, Madam Chair?
Yeah, please.
As far as I'm concerned, yes.
I'm responding, when I mention anecdotes, I'm saying the anecdotes expressed at the beginning of this do not seem to fall within the guardrails of this bill. And yeah, we are aware of expanding scope. I represent physicians, so that's why my statements come from the physician perspective. But in my testimony, numerous times it mentions prescribing clinicians, which include APRNs and physician assistants, who also have that prescribing authority. We just want to make sure that, the problem exists that you identified and is being identified here today. Actually, that problem has not been identified. The problem of, running out of something on Friday at 5 o'clock and not being able to get it until Monday has not been identified once, at least verbally, and I didn't see it on written testimony this morning. That seems to be what we're looking at. That emergency supply of chronic maintenance drugs that, if stopped, will cause distress or maybe some physical harm or behavioral health harm to the individual. We're more than happy to fill that gap. And we're more than happy to, work with the nurse practitioners and the physician assistants to do that. But as I said, these anecdotes seem to be that were presented today. If we want pharmacists to have prescribing authority, broad prescribing authority, then let's have a bill and let's discuss that before the legislature. It's certainly not something to be addressed during a short session. So in our testimony, we see this as a little bit of scope creep, and we didn't see enough guardrails and parameters put forth to cover the truly emergent situations that we're discussing and have been presented to us, at least.
Okay, Senator Brenner.
Thank you, Chair. Nice to see you, Mr. Moran.
Hi.
I just have the luxury of Googling around since we're Zooming, and I was looking at the state of Missouri's pharmacy guidelines in statute, and they have a provision for emergency dispensing by pharmacists. And I'm just wondering, have you heard from the national organization with regard to how they feel about these state level changes?
You know, the Maine Medical Association is part of a federation of medical associations, which include the American Medical Association. We don't fall under their guidance or purview, but we are directly related to them. And to answer your question, the Maine Medical Association would be much more amenable to working with the committee on solving this problem through legislation than the American Medical Association would be.
Thank you.
Okay. I see no further questions from the committee for you, Mr. Moran. So I'm going to transfer you back to our attendee space with thanks for providing the information to the committee. And next we will hear from those who, actually next I'll ask whether there's anyone else in our meeting who wished to speak in opposition to the bill. And seeing no electronic hands raised, I will shift over to those who wish to speak neither for nor against the bill. And let's see, the first person on my list is Sarah Calder, but I don't see her in the meeting. So I will go on to Sam Hallmeyer. Good morning, Mr. Hallmeyer. Go ahead.
Good morning. Thank you, Chairwoman Sanborn, Chairwoman Tepler, members of the committee. My name is Sam Hallmeyer with PCMA, which is the trade associations for the PBMs. I'm here today to speak that we're neither for nor against LD 1776, and I'll keep it brief and refer the committee to the written testimony I submitted. But we just suggested that this be limited to a one-time fill for up to a 30-day supply, which sounds like this was already discussed in previous testimony. So I'm here to answer any questions that the committee might have.
Thank you, and we appreciate your brevity. Are there any questions for Mr. Hallmeyer? All right, seeing none, we thank you. Representative Tepler.
Thank you. So, Mr. Hallmeyer, what do you say to the situation where for the second time in a year, you accidentally find yourself on a Friday without an active prescription for your chronic medication, let's say levothyroxine, or something like that, and you really need a couple days? Are we counting on our pharmacists disobeying the law to take care of that?
Thank you, Madam Chair, for the question. To make sure I understand, so the scenario you're sharing is on if the second time in 1 year on the same prescription, is that what I'm?
Yes.
Okay, I can certainly take that back and get you a response. I don't have that off the top of my head, but I think that's something we could also work out in the rulemaking as well. But let me go back to my members on that for you, and I can get back with you.
When you say rulemaking, you mean Board of Pharmacy rulemaking?
Potentially, yes, potentially.
Or wordsmithing by this committee?
I would be open to either. I think we can certainly discuss this in the work session. Absolutely.
Okay, I think this committee is looking at wordsmithing our own bill because the Board of Pharmacy is so backed up, and we want to be able to help people sooner rather than later.
Thank you, Madam Chair.
Thank you.
Thanks. Representative Brooks, just before we turn to your question, which I see, Mr. Hallmeyer, I wanted to ask about the suggestion for Mr. Marston that we add some language, which I think is in our insulin emergency dispense bill as well, with regard to the prescriber and whether insurance companies should be required. Well, I guess the way to say it is, do we need to add language here to ensure that the emergency dispense is going to be covered as if it were under the prescription that was already being covered by the insurer?
I can certainly take that question back, Madam Chair, and get back to you with a response at the work session.
That would be helpful because, you know, as the PBM representative, you're sort of the gatekeeper there in terms of whether there's going to be roadblocks thrown up to Mainers having their medicines paid for if they rely on this emergency. Okay, Representative Brooks.
Yes, Mr. Hallmeyer, thank you, Chair. Thank you, Mr. Hallmeyer. With a pharmacy benefit manager, I've learned a lot more about that in the last 7 years. So you, as a pharmacy benefit manager representative, represent the people that help manage the insurance medication benefit for insurance companies, and you help keep that cost contained. So one of the things that came to my mind regarding this bill was the issue about access, about pharmacy access. So for chronic medications within a more, possibly a more defined, not the heavily controlled substances and things that people discussed previously. But for my questions to you, I don't know if you know or if you have to come back in the work session with these, but there seems to be an incentive one way financially, like for the patient. If I have a private plan or one of the plans, I'm incentivized to get a 3-month supply mail order to keep it most affordable. And otherwise, sometimes the pharmacies lose money that way. So there are some things.
Brooks,
the question is that, like for the work session, just as far as how long the emergency supply would be, that would help that decision, I think.
Okay.
And then the other quick question I have is, as far as that timing thing, like how long would an emergency supply last? I think that provider pipeline is important to expedite it. And if you could help maybe say if there would be flexibility with if they can see their provider and they see them and their issues addressed within 30 days versus 6 months because of provider availability, that would be helpful.
Thank you, Representative Brooks. So I would just want to repeat back to make sure I understand the question. So your first question was around
around incentivization, like incentives. So I know that for myself, there are some incentives for me to get a, like, I don't want to use a bad term for it, but
so
kind of like
Brooks,
a steering. So within the scope of the bill.
Steering is really outside the scope of this hearing. So I want to move on from that because that would be a really different question and a really different issue. And I think Mr. Hallmeyer had testified that 30 days supply was his suggested amendment to the bill. So I think he has answered your two questions as I understand them. And I want to make sure we're staying to the subject matter of the bill in front of us, or at least things that are directly related to it. And I think mail order supply is outside the scope. So I'm sorry to cut you off, but I want to make sure we're staying on point with this hearing. So Mr. Hallmeyer, I think you've answered the central piece of Representative Brooks' question about the 30 days being the suggested amount to dispense. Thank you. Seeing no further questions with regard to Mr. Hallmeyer, I am going to send him back through the wormhole and bring in Chris Ossenfort. Good morning, Ms. Ossenfort.
Good morning, Senator Sanborn, Representative Tepler, and members of the committee. My name is Christine Ossenfort. I'm the Director of Government Relations for Anthem Blue Cross and Blue Shield here in Maine, and we are testifying neither for nor against LD 1776. I think previous speakers have raised a number of the concerns with the bill. One is clarifying what is considered a chronic maintenance medication. I certainly understand the that pharmacists have the ability to sort of determine whether it's chronic. That's tough for us to implement just sort of on a ad hoc basis. So some clarification of the definition. We would also suggest that it must be a recently expired prescription. It shouldn't be one from 2 years ago. It needs to have been within the last week or 30 days or some reasonable look back. We would also suggest that it be limited so that it doesn't become an opportunity to circumvent the need to go back to a provider and get the blood tests or to make sure that the medication's still working. And that may also be addressed if you incorporate some sort of recently expired prescription. Whether 30 days is the right period or whether it should be 7 days or 14 days may depend a little bit upon the medication. I mean, certainly the committee has explored this issue before with respect to the insulin. We would note that the legislation that the committee passed last year with respect to emergency refills of insulin does not require that the carrier pay for that medication, only that the emergency fill is authorized. We do have some concerns about the precedent of requiring carriers to pay for medication that does not have a valid prescription, that is not typically incorporated into our coverage. And because of that, we would respectfully disagree with the superintendent's letter. We do believe that this is a new mandated benefit because while we cover prescriptions, we cover prescriptions that are prescription medication pursuant to a valid prescription. That would not necessarily be the case in this instance, but that may depend on the final language of the bill as well. So with that, I'd be happy to answer any questions that you might have, and we'll of course attend your work session. And oh, I'm sorry, I do have one other.
Go ahead.
It is enacted, or it is proposed as emergency legislation. That would be very difficult to implement, I suspect, for the pharmacies, but definitely for us. So we would suggest an effective date of January 1, 2023, or some other date specific, because it would be challenging to implement. And as Representative Tepler noted earlier, this would only apply to fully insured plans. It would not apply to the Medicaid program, Medicare, or self-funded plans. So with that, I'd be happy to answer any questions.
Representative Matheson.
Thank you so much. Thank you, Ms. Austin-Fort. So I just want to clarify what you said about the proposed mandate. It's my understanding that this would not be a new service and this would not be a new provider. So under the statute, it seems to me it wouldn't be a mandate. Could you maybe for the work session clarify that, why you think that
Sure.
it is?
I'd be happy to do it, and I'll try to explain it now. I think certainly that's the viewpoint expressed by the Bureau of Insurance, that it's not a new requirement. We're required to cover prescription medications, but only prescription medications that are filled pursuant to a valid prescription. There would be no valid prescription in this instance, at least under the bill as drafted. It would be dispensing an emergency supply without a valid prescription. That is not something we are required to cover today. And that's why I do believe it would be a mandate.
Ms. Austin-Fort, we heard from a number of folks, including providers, that the current practice is that bridge dispensing is done regularly. And in fact, even Mr. Moore told us that he had that happen to him on occasion over a weekend. Does Anthem regularly track down those bridge situations and deny coverage for those 72-hour supply that someone might get on a Saturday morning?
So we wouldn't be billed for those today. Typically, we wouldn't know because we don't receive bill. I will say my dad was a pharmacist, and when I saw the bill, I wondered if this practice bridging still existed. And fortuitously, we actually experienced it last weekend. My significant other went to pick up his metformin, his type 2 diabetes oral medication, and was told by the pharmacy, we don't have it ready yet because we have tried twice to reach your provider and they've not authorized a new prescription. And they said, are you out? we can advance you a few pills, and then you can come back. We did not need to do that. He had plenty still. Typically, I think the practice of pharmacies is often to borrow against the next prescription. So if they give you 5 pills, when you refill your prescription for 100 pills, you will get 95 pills, and we will be billed at that point. I think that's typically the practice, but we would not get a claim for an emergency bridge fill.
In other words, Anthem would be charged for 100 pills, but 5 of them were actually handed out in advance.
Right. That's what I believe happens typically today.
Okay. So with regard to a mandate, if we were to clarify this area of the law to legalize the type of bridging that is already occurring, but to make it a bright line practice rather than a gray area practice, there would be no added expense versus the current practice that exists today. Isn't that the case?
Well, that depends on how you structure it, because if they get a 30-day prescription and then they get a new 90-day prescription, well, I will take that back and ask. I don't want to answer off the top of my head without thinking it through. And we presume that because the legislation, and I think this came up in previous testimony, the legislation does require us to make it available in the same manner as other drugs provided in the policy. So presumably we would be able to impose any applicable cost sharing on the fill in this instance.
Right.
I'll take
thanks. And presumably there wouldn't be any issue with regard to prior authorization or step therapy, because we're talking about a prescription that was previously, already previously filled. But I suppose there could be edge cases where that might come into play.
There could be, and it'd be those, I will check on that as well. It could potentially be those instances where ongoing monitoring is required, to make sure that it's not having an adverse impact. But again, that would tie back to also the length of time. Is it 7 days? Is it 30 days? Because those can obviously have significantly different impacts.
Sure. Ms. Ossenford, can I just play this out again with you, which is to say that I think there are some medications that where the minimum amount you can dispense is quite a lot. I'm thinking of an Advair inhaler, for example, that might, if used as a rescue inhaler, last for 30 days or even longer than that, depending on how frequently you need it. So would you do some work on some language around what the sort of, and I guess that this is a question for Mr. Hallmeyer as well, around what the language might be with regard to minimum dispensable quantity, or 72-hour supply, or 7-day supply, or something like along those lines that would help the committee.
Certainly. And I think you may have had some language that ties to that in the original version of the emergency insulin dispensing.
I think that's right. Yeah.
Yeah.
Okay. Thank you. Representative Brooks.
Yeah, also for the work session, or if you want to comment on it briefly now, and I'll just not to belabor this, but just this is also you misspoke briefly, Chair Sanborn. Just albuterol is the rescue and Advair is more the maintenance, similar to the
Sorry, I don't have asthma.
Easy,
so
yeah, it's
go
easy
ahead.
to the background, but I have
Yeah.
both. With the question I had for you is, it must be really busy this time of year with plan year changes or whatever else there's a plan year change in the formulary changes, just with different quantity limits and clarifications. And I just don't know if you have access to that data, like as far as the call area, customer service, those things, how busy that gets this time of the year, or when there's a plan year change for a group of people.
So obviously, as you noted, particularly with the individual market and open enrollment, things get a little bit busier. But in this instance, they'd be calling the prescriber for authorization rather than for us. And I will say that in my significant other's situation, obviously provider offices are very busy right now with COVID and everything else. And so there can be some delays in that, but I don't know that our customer service lines would necessarily be impacted by this bill or have an impact on this bill.
Representative Brooks, did you want to clarify your question, or does that take care of it? Okay, great. Thank you, Ms. Austin, for it. And we'll send you back through the wormhole and welcome Catherine Pelletreau to testify neither for nor against. Good morning, Ms. Pelletreau, go ahead.
Good morning, Senator Sanborn, Representative Tepler, members of the committee. My name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans, and I'm here to testify neither for nor against LD 1776. You've heard a lot of discussion of the various issues and much of what I was going to say, so I won't belabor it. I'll just touch on a few high points. We understand that things happen and you can't always get the prescription just when you need it or just when you expected to need it. So that's first, especially during COVID times. That said, there should be some limitations. As you've heard, we'd like limitations that the drug be covered drugs only, which I think the bill pretty much covers because it's an existing prescription. The emergency access issue with the focus on emergency access. So what constitutes emergency access? I heard the question from the committee about should it be one time? Should it be more than one time? I will take that back and ask that question. We've, like others, suggested 30 days. And, the last thing I would say is, and I think this has also been mentioned, is explicit about the collection of cost shares, which I think Senator Sanborn mentioned that it's being filled under the auspices of the existing benefit design. So to the extent that includes cost shares, those would be included. So I'll stop there. I'm happy to take any questions.
Are there questions for Ms. Pelletreau? All right, I don't see any. Thank you for joining us today. Unless Ms. Calder has joined us, which I do not see her, but she did file written testimony. So that concludes the list of folks that I had signed up to testify today for this bill. So if there's anyone else in our meeting who wishes to testify on this bill, please raise your hand at this time. And seeing none, I will close the hearing on LD 1776. And we are likely to schedule this for a work session on Tuesday next week. And just for the committee's information and for those who are joining us, we have many of our usual attendees in attendance. We are planning to meet on Tuesday. But it'll be work sessions, and we haven't accumulated yet which bills it will be, because it'll be largely those we're hearing today that we're going to be working on Tuesday, and that'll get noticed probably tomorrow. So that's where we are at the moment. The next bill is 1837. I expect it will be a much shorter hearing than the last one. So I'm going to suggest that we just power through and proceed with our work. But certainly if folks need to take a short break, they can turn off their video and step away from their computer if they need to. So with that, I will turn the gavel over to Representative Tepler, and then I'll present my bill.
Thank you, Senator Sanborn, and I invite you to introduce LD 1837.
Thank you, Representative Tepler and colleagues. I am here today to introduce LD 1837, an act to clarify the appeals process for decisions related to the Maine health insurance marketplace. This is a Department of Health and Human Services bill that seeks to address the potential conflict between state and federal requirements for the Maine health insurance marketplace appeals process. Federal law requires that state-based insurance marketplaces offer consumers the ability to appeal certain decisions. The entity here in Maine that handles this is the Division of Administrative Hearings within DHHS, and consumers are able to further appeal a decision to the U.S. Department of Health and Human Services. However, Maine's Administrative Procedures Code and Code of Civil Procedure also specifies that a ruling from the DHHS Division of Administrative Hearings is subject to judicial review. This bill simply clarifies that these decisions are not subject to judicial review in Maine and that they are to be appealed to the US DHHS. Appealing to the department is a simpler process that's more advantageous for consumers. And additionally, they are the appropriate agency to handle these appeals since they are the ones that oversee the Affordable Care Act. A staff member from DHHS will be speaking after me to provide additional details and answer questions, but I would be happy to try and answer any questions that you might have for me, but you shouldn't ask any. Thank you.
Thank you very much, Senator Sanborn. Are there any questions from the committee for Senator Sanborn, even though she doesn't want them? Seeing none, I will turn to Ms. Garrett Reed and ask her to please join the panel and present the department's testimony. Welcome, Ms. Garrett Reed.
Thank you. Senator Sanborn, Representative Tepler, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. I am Megan Garrett Reed, and I am the Director of the Office of the Health Insurance Marketplace within the Maine Department of Health and Human Services. I am here today to testify in support of LD 1837, an act to clarify the appeals process for decisions related to the Maine health insurance marketplace. This is a bill submitted by DHHS and was drafted in collaboration with the Office of the Attorney General to address a potential conflict between federal and state requirements for the Maine health insurance marketplace appeals process. We extend our thanks to Senator Sanborn for introducing this bill on our behalf. The Federal Patient Protection and Affordable Care Act, known as the ACA, requires that state-based marketplaces allow consumers to appeal certain decisions of the marketplace to an appeals entity. For Maine's health insurance marketplace, this entity is the Division of Administrative Hearings within the Maine Department of Health and Human Services. Federal regulations at 45 CFR Part 155, Section 520C also require that a marketplace consumer who is dissatisfied with the decision of a state appeals entity must be permitted to further appeal the decision to the United States Department of Health and Human Services. Under Maine's Administrative Procedure Act and Code of Civil Procedure, however, a decision of the DHHS Division of Administrative Hearings would constitute final agency action and therefore be subject to judicial review under the Maine Administrative Procedure Act and Maine Rules of Civil Procedure, Rule 80C. Although unlikely, these dual options for escalation of appeals could theoretically result in conflicting decisions and uncertainty about which decision should be implemented by the Maine health insurance marketplace. The Office of the Health Insurance Marketplace requests your support for this legislation in order to establish a single process for appeal of decisions of the Division of Administrative Hearings in marketplace cases in light of the required federal escalation pathway. We also believe that relying on the United States Department of Health and Human Services appeals entity is in the best interest of consumers, given the less administratively and legally complex process for pursuing that appeals channel and the speed of decisions issued. Finally, the decisions subject to appeal are related to determinations of eligibility under the ACA, an area of law which the federal agency administering the program is well qualified to consider. Thank you again for the opportunity to testify. I would be pleased to answer any questions you have now or at the work session.
Thank you, Ms. Garrett Reed. And I see that Representative Matheson has a question. Please go ahead, Representative Matheson.
Thank you, Madam Chair. This is kind of a silly question, but thank you so much for your testimony. I just wanted an example of what an appeal would be. Are we talking about, could you just give me an example? Thank you.
Yes, happy to do that. The topics or decisions that consumers can appeal are somewhat narrow. Essentially, they focus on decisions about whether or not the consumer is eligible to purchase a plan through the marketplace at all. There are some very narrow categories of people who can't. For example, a person living outside the state of Maine is not eligible to purchase a plan through coverme.gov. And then the other decisions are those about qualifying for advanced premium tax credits and the amount of advanced premium tax credits that the consumer is eligible for.
Thank you, Ms. Garrett-Reed. I think Rep. Matheson is satisfied with that answer. Are there any other questions from the committee? Seeing none, I have no one else on my list to testify in favor of the bill or in opposition to the bill, or neither for nor against the bill. I see the department is here. I don't know whether they have an opinion that they want to share, the Bureau of Insurance, but I think not. So with that will bring to a quick close the hearing on LD 1837. And I will turn the gavel back over to Senator Sanborn as we have each sponsored a department bill that's being presented today.
Thank you, Representative Tepler. So next we'll open the hearing on LD 1842, and I will look to Representative Tepler to introduce the bill.
Good morning, and I apologize for not having submitted any written testimony on this bill. It is a highly technical bill from the Maine Health Data Organization. I will ask you not to ask me any questions about the bill. It involves legislative review of portions of Chapter 120 and the release of data to the public. And I hope that you will ask any questions you have about the content of the substantive rule of Ms. Karen Lee Harrington, who will testify after myself. Thanks very much.
Thank you, Representative Tepler, and I am going to bring in Ms. Harrington. She's going to be joining us now. Good morning, Ms. Harrington.
Good morning. I'm going to leave my camera turned off because I'm having some unstable internet messages. Sure. But it's great to see everybody. Senator Sanborn, Representative Tepler, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Karen Lee Harrington. I'm the Executive Director of the Maine Health Data Organization, and I'm here today to present testimony in support of the proposed changes to 9590 CMR Chapter 120, release of data to the public. I'm going to refer to that rule as Chapter 120 throughout my testimony. So the Maine Health Data Organization, our data are obtained to fulfill MHDO's legislative mandate to create and maintain a useful, objective, reliable, and comprehensive health information database that's used to improve the health of Maine citizens and to issue reports promoting public transparency of healthcare quality, outcomes, and costs. The MHDO will make data publicly available and accessible to the broadest extent consistent with the laws protecting individual privacy and proprietary information. The primary use of the MHDO data is to produce meaningful analysis in pursuit of improved health and healthcare quality for Maine people. Acceptable uses of our data include, but are not limited to, study of healthcare costs, utilization, outcomes, benchmarking, quality analysis, longitudinal research, other research, and administrative or planning purposes. The purpose of Chapter 120, release of data to the public, is to specify the permissible uses of the MHDO data, to define the various levels of our data files, which include level 1, 2, and 3 data, the process for which data requests will be reviewed and data released, the public notice requirements of data requests, the terms and conditions of our data use agreement, MHDO's internal use of the data, and our security and protection requirements. The data available through MHDO is the most comprehensive healthcare claims and hospital encounter data accessible to a broad group of authorized data users, including researchers, policymakers, hospitals, providers, healthcare purchasers, and consumers. For MHDO's data to continue to be relevant and support various healthcare research and analysis, the data collection and data release rules must adapt to the changing needs of our data users and healthcare data availability. For example, with the enactment of LD 541, an act to improve healthcare data analysis, MHDO and the Department of Health and Human Services, the Maine Center for Disease Control and Prevention, specifically the Data Research and Vital Statistics Department, together adopted a joint rule in December of 2021 that now provides for the reporting of cancer and vital statistics data by the department to the MHDO. MHDO is then required by statute to integrate this data into MHDO's existing data sets. The integrated data, as we've discussed, will provide a much more comprehensive set of data for authorized data users working on cancer research in Maine. In order for us to release this integrated data set, we must update Chapter 120, which is the rule that is before you. Additionally, the proposed changes update several definitions, specifies quality measures that MHDO collects and releases to reflect changes in our rule that governs the collection of these data sets. The MHDO Board of Directors met on May 6th of 2021 and authorized MHDO to initiate rulemaking. And remember, this obviously, as it's before you, is a major substantive rule. The proposed rule was publicly noticed on October 13th, and a public hearing was held on November 4th before the Board of Directors. The board met on December 2nd and reviewed the one public comment received regarding the proposed changes, and they considered staff's recommendation on how to address the comment. A copy of the MHDO's basis statement, which is attachment A in your packet, includes the identification of the individual submitting the comment, MHDO's staff recommendation to address the comment, and the board's action specific to the recommendation. After consideration of the comment and staff's recommendation, the board unanimously voted to provisionally adopt the rule changes that are presented to you today. Also attached to my testimony is a description of each proposed change and the rationale for the change, and that's attachment B. And there's also a copy of Rule Chapter 120 with the proposed changes identified in track change, and that is attachment C. So there's a lot of documentation here, and as Representative Tepler mentioned, it's pretty technical. I'm happy to go through the various changes if you'd like to do that now or during the work session. The sources that we relied on in proposing these changes included requirements in Maine law, consultation with our data user group, and I included a link if you're interested in who the membership of that group, who those members are, recommendations from the MQF Primary Care Spending Advisory Committee, and then consultation with our data vendor. That concludes my testimony, and I'd be happy again to answer any questions here or at the work session.
Thank you, Ms. Harrington. Are there questions for Ms. Harrington? All right. Seeing none, we thank you for explaining this substantive rule to us this morning. And I will look to our attendee space to see if anyone wishes to provide additional testimony in any capacity on this major substantive rule today. Seeing no hands go up, I'm going to close the hearing on LD something or other. LD 1842. And so with that, we have concluded our work for the morning. And we do have work sessions scheduled at 1 p.m. today with the anticipation that we would have a lunch break and time to meet with our respective caucuses over lunch if that is to be desired. And So we will reconvene here at 1 o'clock. And again, just to note that the two bills we just heard are likely to be worked on Tuesday as well. So thanks so much, everybody. And right, I already mentioned the first one would be worked on Tuesday, and then these two as well are likely to be added to our schedule for Tuesday. So I'll see everybody back here at 1 o'clock. Thank you. Edna, could you take down the screen share so we can see how many folks we've got present with us? Thanks.
Hi, I've got Mary Ann with me to help me with the work sessions.
Okay.
Hi, Mary Ann.
Hello, Representative Tepler.
Welcome back, everyone. Just had to run and save my dog from the big, scary UPS man. So I think we're okay now. All right. Representative Morris, Representative Bleier, are you with us? All right. Well, it sounds like they're not back quite yet. But I will give it a minute. There's
back.
Representative Morris.
Should be,
great.
yeah.
Okay, perfect. Well, we're going to get started then and pick up our work for this afternoon. And let me just get a little organized here. Whoops. Great. Okay. So the first bill on our docket for this afternoon is LD 1752, which is an act to provide insurance coverage for a beneficiary on a transfer on death deed. And I'm going to start by asking Colleen to go over her bill analysis and the amendment that has been proposed.
Okay, great. Okay, I think everybody can see this. This is the, I'll start with the analysis and then quickly go through this and then go over the proposed amendment that was shared yesterday based on some discussions among the sponsor, Senator Sanborn, and some of the interested parties. But LD 1752, as it's drafted, is a bill that is intended to require a property insurance insurer to include as a named insured on a contract of property insurance a designated beneficiary for a property for which the designated beneficiary has been named on a transfer on death deed. The language of the original bill would provide that the insurer may not cancel the contract for at least 30 days after the death of the transferor of the property, and provides further that the designated beneficiary does not have an insurable interest in the property until after the transferor's death. And we did get both written testimony and verbal testimony on the bill at the recent public hearing, and at the link to where you can find all that is included. But I think, as you heard at the public hearing, Maine law since 2019, when the probate code was updated, includes the authority for a transfer on death deed in statute outside, and it sort of provides a process outside of the probate process to provide for a transfer on death deed. It's based on a uniform law that's been adopted in a number of other states. As I said, you did hear from representatives of insurance companies, insurance producers, and the Bureau of Insurance in their testimony about the bill. But from the insurance company and insurance producer perspective, they did raise some concerns about the language of the bill as drafted, including sort of the approach the bill took to designating the beneficiary as a named insured. They were concerned that that would bind insurers to contracts with unknown and unfamiliar parties, that it would have an impact on their potential liability and could impact their premium because it would be difficult to determine the risk. They also cautioned that they thought that the use of this type of deed may create pitfalls, and it's a clearer process, at least in terms of how insurance coverage is handled when property is transferred through the probate process. Although, as I mentioned, this is a recent change to Maine law that authorizes transfer on death deeds. They also expressed some concerns about the provision that would prohibit a insurance company from canceling a policy for any reason for 30 days. The Bureau of Insurance testified neither for nor against, and also suggested some technical changes for the committee's consideration. They noted that the bill provides that a designated beneficiary has an insurable interest in the property only after the death of the transferor. And under existing law, they may well have an insurable interest in the property both before and after the death of a transferor. And they suggested that the committee consider whether the language as drafted might restrict a beneficiary from protecting against financial loss by obtaining insurance of their own before the transferor's death. They also noted that the bill as drafted is put in a section of the statute that applies to property insurance generally. So it would apply not only to homeowners insurance, but commercial insurance and insurance on other types of property. And they suggested that the committee consider, given the intent of the sponsor, that this be applicable to homeowners insurance, whether the provision should be allocated to the specific section of the insurance code that applies to homeowners insurance only. And as I mentioned, Senator Sanborn worked with, got some input from the Bureau of Insurance, and based on their discussions with interested parties, suggested an amendment to the bill that would attempt to address some of those concerns that I just noted. The amendment would replace the bill and make other technical changes. One of the changes would be to move the provision to the section of statute that applies only to homeowners insurance. It would require a property insurance insurer to extend coverage for a limited time to a designated beneficiary named on a transfer on death deed when the transferor dies. It would provide that the insurer may cancel the contract within 90 days, as is currently allowed under what's called the Maine Property Cancellation and Control Act, and that the policy would automatically cancel as of the transferor's death if the insurer has not received a notice of death affidavit, which is provided for under the probate code now, within 30 days of after the transferor's death. The amendment also contains provisions that would limit the coverage to the property transferred, would require the beneficiary to comply with the policy conditions, would allow the insurer to request proof of the transferee status as a designated beneficiary, and then also provide some language that if there are multiple designated beneficiaries, it would limit the insurer's liability to what it would have owed the transferor at the time of the loss. We don't yet have a fiscal note that's been completed on the bill, but I guess I'll stop there, and I'm also happy, I'll switch over and pull up the actual language of the amendment if that would be helpful for the committee to see. I would note that the bill as drafted is an emergency, so if the committee moves forward with the emergency preamble and the emergency clause, It would require a 2/3 vote of the committee. One thing that came up that I thought of this morning when we were talking about some of the health insurance bills, typically we will provide or add a specific effective date or an application date. That isn't something that I think is included here. I don't know if it's necessary. It's just an additional issue that I thought of. But if the bill does become effective as an emergency law, it would become, the effective date would be the date that the governor signs the bill into law. So the amendment just shows in bold italicized language where the Bureau of Insurance, where the proposed amendment makes changes to the original bill. The highlighted section really is just showing you that this is being moved to a different section. As I mentioned, that applies to specifically to residential property, property insurance on residential property. This is subsection 2 is taken from what was in the original bill and modified to clarify that when an insured property passes to a designated beneficiary under a transfer and death deed, the policy covering the insured extends to the designated beneficiary, subject to the further provisions of the statute of the proposed amendment. And then here you'll see we add the provision related to cancellation, that the carrier can cancel the extended policy as if it had been in effect for less than 90 days, unless the insurer receives a notice of death affidavit within 30 days after the transferor's death. And the date of cancellation is deemed to be the date of the transferor's death. This is the provision, subsection 4 is the clarifying language that the extension of coverage applies only to with respect to the premises and property of the transferor. Subsection 5 is the provision that allows the insurer to ask for documentation that the party is the designated beneficiary under a properly recorded transfer on death deed, and they've filed that notice of affidavit, which is required under the probate code. Subsection 6 is the provision that relates to the insurable interest of multiple beneficiaries. I'll stop there and I'm happy to answer any questions. I do know that you have in the attendee space both representatives of the Bureau of Insurance and some of the other parties that were part of the discussions on this proposed language.
Thank you, Colleen. I'm going to start by asking if the committee has questions for Colleen. Representative Morris.
Thank you, Madam Chair. Yeah, you spoke about it being an emergency. Is that usually done in I know sometimes with health insurance stuff, we try not to do emergency legislation. Is that usually recommended with this type of insurance as well?
I mean, sometimes often when we are making changes to contracts, whether it's in the health insurance area or in other sections of statute, the committee will often provide a specific application date, that this applies to policies, issued or renewed on or after a specified date to allow some advance sort of time for compliance on insurers. This isn't something that I was able to raise. It's just something that occurred to me this morning, and I didn't have a chance to raise it back to the Bureau of Insurance or to the folks that talked about this bill as to whether it would be useful here. But the emergency preamble was included in the original bill as brought forward by Senator Bailey, the sponsor.
Okay.
Let me see if I can take a stab at that question as well, Representative Morris. I don't think it's necessary in this case to have a date certain because the circumstance where this bill would come into effect is the sort of tragic circumstance where there's actually a loss within 30 days after the death of a transferor who happens to use this type of instrument in order to transfer their property. The likelihood it's going to come into play, in Maine in the next year is probably very low, given that the law has only been in effect for a few years. So perhaps people haven't used it all that often yet in terms of their estate planning. But I think in the circumstance where it did happen this November, for example, and someone was unable to recover the value of the home that they had just inherited that then burned down 3 days later, we would feel pretty terrible if we had extended it out to January 1st for no particular reason other than maybe the comfort level of not setting a precedent of changing things mid-year on an insurer. So I hope the committee will go along with this as an emergency if we've done our work, which I think we did, to try and redraft this in a way that precisely targets the scenario that we were trying to get at without creating any unintended consequences. So I hope that helps. Representative Brooks.
Yes, I had a question for Colleen and perhaps people that are in the audience as well. So I think it's a great initiative, and that it's important for loved ones and people planning for the possible eventuality that this might happen. And I am familiar on some levels with the process, but really not as familiar at all with how the probate court interacts with insurances. So if you could answer this question, just in this scenario, so we had heard about the case where somebody's loved one died, and then a couple days later, 3 days later, the house was burned down and they lost everything basically. So in this improvement to the bill, I'm not clear on, like, right now, so we have the 30-day and 90-day guidelines. So as far as specifically insurance, if it's 91 days and the person is still like in mourning, or there's multiple family members, what kind of is the insurance company under right now no obligation? Let's say that somebody's grandfathered, they have the deceased has a great insurance plan, they've been with them forever, they have a lot of property insured, but then the loved one has a limited resources and maybe the paperwork isn't as clear as people haven't discussed it in length. Are there protections for the person if it's 31 days or 35 days or something, like they're in the hospital or something? What are there provisions that help them?
Well, I think you might be asking two different questions. I mean, I think there are provisions possibly, and I might not be completely understanding you, but currently if someone has insurance coverage and their property is being transferred to beneficiaries as part of the estate process, my understanding is the estate takes ownership of, the estate stands in the place of the named insured for a period of time to allow the extension of that coverage through the probate process. So I think, as I understand the testimony that we received and what I understand of the interplay between property insurance and the estate probate process, those situations are covered now. What Senator Bailey's bill was intending to do was to address the narrow situation that Senator Sanborn mentioned, where property is being transferred outside of the probate code process. So the estate does not become the owner of the property upon the person's death, but the transfer on death deed is executed before someone dies and names someone as the designated beneficiary of that property, and they become the owner of the property upon that person's death. And it's more the current law and the current insurance process, as I understand it, lacks clarity as to how to address that situation now, or Maine law does. It lacks clarity on that. And there have been some court cases that have been decided in other states that have found that a beneficiary under a transfer on death deed, if there has been a circumstance where the property is destroyed, at a short period of time after that person's death, the court decision has been that the designated beneficiary does not have the benefit of that insurance coverage. after the person dies. So the bill is trying to get at that narrow situation where Maine law allows property to be transferred upon someone's death outside of the probate process. And there's a need to have some clarifying language as in the sponsor's view of how the insurance coverage should be determined. And this bill would allow that period of time for the coverage to extend to someone who takes ownership upon someone's death for that 30-day period, and then they can follow along the other process that's required to execute or to, take ownership pursuant to that transfer on death deed by filing a notice of death affidavit. And, then the insurance company has some surety about and clarity in the statute about how to deal with those situations.
Thank you.
Okay. And I'm comfortable with this amendment, obviously, because I helped to write it. But I'm looking to the committee for input as to whether we want to hear directly from Mr. Wake or Mr. Yardley from the Bureau. I assume those are the folks who might provide us additional insight if we had questions for them. So I guess I'll look for electronic hands from the committee if folks want to speak to the Bureau. All right, I'm not seeing any. Is there anyone on the committee that wants to make further comment or has additional questions about the bill?
Ooh.
Representative Morris, go ahead.
Oh, yes. Thank you, Madam Chair. I did notice the Honorable Bob Foley's hand up in the attendees. I did talk with him as well, and he was comfortable with it. I don't know if he might provide some insight as well, because I know he said he worked with you on this. So
yeah, that would be great. I am not at the moment appearing to be a host.
I'm pulling him in. I've got him.
Thank you.
He's coming over.
Great. And Edna, if you're able to make me a co-host, that will help facilitate the meeting. Thanks. Perfect. Wonderful. Now I am.
Yeah.
And
there he is.
Great. Good afternoon, Honorable Mr. Foley. Did you want to comment on the amendment?
Yes, thank you. And thank you very much for working with us on making these clarifications. And I think that they're good answers to the issue. And as far as the 30-day or the emergency, I think it's fine to let it go into effect immediately. It really clarifies language that's already in the policy that gives the insurance companies direction if in fact they're faced with this. The only question that I did have was the original draft that we had under the cancellation had the affidavit had to be presented within 10 days. And this new one that I'm seeing says 30 days. And I think the 10 days we had in there because that's consistent with the probate law. And so I'm not sure where the 30 days came from, or if that's something that was put in and how it came. That was my only question on that particular part of the amendment.
Yeah, so I can address that. The initial draft that I saw actually said 7 days. And I thought that was particularly in the context where this is a transfer on death deed. You don't necessarily even know that you're the beneficiary of it, and the funeral may not have even been held yet. Those types of things. I was concerned because the effect is quite cataclysmic. If there were a loss, you'd have no coverage at all. So I felt that 7 days seemed too tight. I think 10 days might be fine if 10 days is what is in the probate code. 7 days seems like, that's 5 business days. That's not very long to figure this all out. If you are the beneficiary, you might not be the personal representative, I guess is the point. So you may not be as familiar with the legal processes that are going on in terms of the probate part of the estate. This operates as a matter of law, so it can happen like that without your awareness. Colleen, can you speak to the timelines in the probate code? What's the triggering event and how does that all play out?
I'm just looking back at the statute of the probate code. I don't see a specific date in the probate code. In my discussions with the Bureau of Insurance about where the 10 days came from, it was consistent with some of the notice requirements now for notice of cancellation pursuant to the Property and Cancellation Control Act. So that's where I thought the origin of the 10 days was, but maybe they can clarify that for me as to why that was included in the original suggestion, as you said, Representative Foley, and former Representative Foley. And then I think, as Senator Sanborn said, there was some thought that that may not be long enough and suggested the 30 days.
Yeah, and I could be wrong that the Bureau was the one that suggested the 10 days and where they came up with that. And it could be under the Cancellation Control Act. So perhaps they could answer that. I was just curious to make sure it's consistent with wherever they pulled that out of. But other than that, I think this is a great answer to the issues that the Senator Bailey brought up regarding this. And I think it works just fine. And I appreciate the effort that people put into it.
Madam Chair, I see Mr. Yardley has his hand up.
Great. Thank you for the help. I'm obviously on my other screen trying to find the answer to what happens in probate as well. Thank you. I'll bring in Mr. Yardley. Oh, and I also see that Senator Bailey is in the meeting. I don't know if she was there before. I didn't see her before. I'm going to bring her in because she may know the issue of notice and how that functions within the probate scenario based on her professional experience. So we'll have her on the panel as well. Mr. Yardley, go ahead.
Thank you, Senator Sanborn, Representative Tepler, and members of the committee. I'm Ben Yardley, Senior Attorney with the Bureau of Insurance. There, when we were working on the proposal, I looked at the Cancellation Control Act. There are 2 periods of time for allowed to an insured to cancel a policy. One is 10 days for non-payment. The other is, I think, is 20 days for other reasons. And the 10 days just seemed to make sense to me. There wasn't particular magic involved. It was consistent with that portion of the Control Act.
Mr. Yardley, when you say it's 10 days, so does that mean that at 10 days, the insurer would then have to send you a notice? Or does that mean that as of that 10 days, they can retroactively cancel your policy if your payment's 10 days late? Is that the impact of those 10 days? Because this is a pretty strict, like a pretty harsh 10-day requirement,
right?
On
We're
the enrollee.
The period is just something that I picked.
Okay.
In the Control Act, there's a mailing period that's added on. It's either 3 or 5 days. This doesn't, just see whether this answers that question. Well, as drafted, the amendment says that if the insurer does not receive a notice of death affidavit within 10 days after the transferor's death, the policy is deemed to have canceled as of the transferor's death without any further action by the insurer. So it'd be automatic.
Yeah.
And that's
it's
to give
a very
some
harsh penalty.
Which perhaps could be played with by changing the period of time.
Okay. Okay. That's helpful. Senator Bailey, welcome to the panel. And we're trying to determine in our bumbling way here, I think, what would happen in probate in terms of the time frame in which these things get initiated in probate. I think that's the real issue here, because the way this has been drafted, it requires the beneficiary to take an affirmative action of sending an affidavit of death to the insurer in order for the coverage extension to kick in. And we're trying to set a time frame on that initiation of that notice by the beneficiary. So I was wondering if you could provide us any insight from the probate landscape as to what that initiation time period might be.
Yeah, there really isn't any. I'm thinking that what the Honorable Mr. Foley may be thinking of when he talks about a 10-day notice is the part of the probate code that requires if a personal representative is going to sell real estate, they have to give at least 10-day notice to the heirs and the devotees. So that's the only 10-day notice requirement that I'm aware of that has something to do with real estate, but it really has nothing to do with what we're discussing here. I do think that a hard 10 days, if you haven't given the affidavit to the insurance company, then it's retroactively canceled, is harsh and is not enough time, which is why I think the 30 days is more reasonable. Just again, as you mentioned, I mean, we're talking about someone's passed away, you have a funeral, you may not even know that you're the designated beneficiary, and you have to then take this affirmative step, which may require you, talking to an attorney and getting an appointment with that attorney. 10 days seems just too short a time. So I would ask the committee to adopt the amendment with the 30-day notice.
Great, thank you. Representative Tepler.
I just want to indicate that I agree with Senator Bailey. I went through a probate process personally with my mother's death as the personal representative. And just a lot of things take more time than one would expect in that process. And I can't imagine that it's really that much different with the deeded claim to the property. I just think that with a death, people need to be allowed a bit of time to undertake the duties that are incumbent on them in terms of their inheritance.
Thanks. Representative Brooks. Representative Brooks, you're on mute.
Sorry about that. So I was thanking Senator Bailey for bringing the chair and Senator Bailey for the attention to this matter and bringing this issue forward. It definitely is a challenging time around when a loved one or somebody that's that you love passes away. Also, interested parties could be a lot of people involved, whether that's the person living in the house or maybe a child or sibling or somebody else that was designated or not designated. So my concern is with the length of time, it still might not be enough. Do you know what I mean? Like with like, especially like with a long-term policy, if the person is leaving a lot of things that are precious to maybe the family or for somebody living there. But with coronavirus, especially, this is a very timely bill because just, yeah, I won't say too much about that, but winter in Maine and across the nation too. So I appreciate that. And I'm wondering about your expertise on probate and this bill to cover the gap and bridge, and that you feel 30 days. Do you think 30 days is enough given the scenario? And Dr. Sanborn, Heather Sanborn, Senator Sanborn, the chair, asked something about triggering probate or triggering a notice. Like, do we now have something in place that, let's say somebody lives there but might not be the one named as the executor or the or maybe with an old will, what do we have in place currently as a protection?
So Representative Brooks, I'm gonna try and just like kind of narrow down the questions. I think let me just, because I think there's a couple of different questions and some of them are answered by probate and are not really on point for what we're talking about today. But I think we can have Senator Bailey address the question of whether 30 days seems adequate in your experience. Senator Bailey, do you want to just speak to that briefly?
I think 30 days is a fair amount that, we're trying to balance the interest of the insurance company and not have this lingering forever. But by the same token, again, give people adequate time to kind of regroup and get affairs together and stuff. So I think 30 days is adequate and fair.
Great. And Mr. Foley, did you want to weigh in on the 30 days after our discussion as well?
Thank you, Senator Sanborn. Yes, I'm fine with the 30 days. I just wanted to get clarification as how that changed and how the Bureau came up with those 10 days. But I think 30 days is certainly reasonable and something that I think the companies can work with. And I think it certainly makes it defines the time frame for both the beneficiary and the insurance company, so they have a definitive time where they need to do things.
That's great. Thank you. All right. Are there any additional questions for Senator Bailey or the Honorable Robert Foley? All right, seeing none, I'm going to send you back to the attendee space. Thank you very much for being here to provide that extra insight. I'm going to send Mr. Yardley back. Oh, somebody already did, I think. Yep. Okay, great. So is there any further committee discussion with regard to this bill? All right. Seeing none, I would entertain a motion. Representative Tepler.
Thank you, Madam Chair. I move ought to pass as amended by the amendment created by Senator Sanborn in conjunction with the Bureau with the 30-day notice included.
Yep. Great. Is there a second? Seconded by Representative Evans. And I'm just going to check in with our clerk and make sure she's all caught up and with us. And this is our first vote, I think, our first roll call vote on a bill. So we are ready for the question.
Thank you. Okay. Senator Sanborn?
Yes.
Senator Brenner?
Yes.
Senator Stewart?
Yes.
Representative Tepler?
Yes.
Representative Osborne?
Yes.
Representative Bleier?
Yes.
Representative Brooks?
Yes.
Representative Connor? Representative Connor, absent. Representative Evans?
Yes.
Representative Matheson?
Yes.
Representative Malorano?
Yes.
Representative Morris?
Yes.
Representative Quinn?
Yes.
I think Senator Stewart vote.
12 have voted
Okay.
in favor.
Perfect.
One absent.
Great. And one absent.
Thank you.
Madam
Okay.
Chair?
Yes.
Madam Chair, it might behoove us to remind Representative Connor that he has, I think, 24 hours to register his vote.
Yep. We will we'll follow up on that. He's not here for us to remind him at the moment, so we'll send out an email. Great.
Yes, I will send that out today.
Perfect. Thank you very much. All right. Good. We remember how to do this work session thing here. All right. So we're going to move on, and Representative Evans has rejoined our meeting. So we will pick up LD 1778, an act to improve healthcare affordability and increase options for comprehensive coverage for individuals and small businesses in Maine, brought to us by Representative Evans. And I'll ask Colleen to provide us with her bill analysis.
Okay, great. What up here? Here's LD 1778 as Senator Sanborn said, this is a bill to improve healthcare affordability and increase options for comprehensive coverage for individuals and small businesses in Maine. The bill has two sections. The first section would direct the newly created Office of Affordable Healthcare beginning in 2023 to analyze barriers to affordable healthcare and coverage and develop proposals on potential methods to improve healthcare affordability and coverage for individuals and small businesses in the state. And then the second section of the bill requires the office to specifically study the effects of certain policies aimed at improving healthcare affordability and coverage, including effects on affordability of premiums and cost sharing in the individual and small group markets, and the effects of the policies on enrollment in comprehensive health coverage. It would direct the office to provide a report of its findings to the committee with jurisdiction over health coverage and insurance matters no later than January 1 of 2023. And you can find the written testimony in the electronic LD file for the bill. As I think I noted, this is a newly created office that was established as a result of the committee's consideration of LD 120 last session. It became Public Law 2021, Chapter 459. The law became effective, and there's a typo there, it's October 18th, 2021, not October 1st. It was established as an independent executive agency for the purpose of analyzing healthcare costs in the state. That was its primary purpose. It also includes other duties to provide staffing to the Maine Prescription Drug Affordability Board as well. As I think you may know from the discussions and at the confirmation hearings you had earlier this week for nominees to the Advisory Council to the Office of Affordable Healthcare, the office has not been fully implemented yet. There is a letter that the committee received from the governor's office about LD 1778 that notes that they are currently considering candidates for the position of executive director. And that will be a position once the governor nominates someone to the position. It will be subject to review by the Hcifs committee and confirmation by the Senate. A couple of issues that you may want to consider as you think about LD 1778. Consider whether or not you might delay the reporting date pursuant to subsection 2 of the report. As I mentioned, the bill as drafted requires the report to be submitted January 1 of 2023. The sponsor has indicated a willingness to extend the date, suggested extending the date to January 1 of 2024. And you did, as I mentioned, have some concerns expressed in testimony that you received about the timing and adding to the statutory duties of the office when it has not been fully implemented yet. That was a concern that was both noted by the governor's office and some of the other testimony you received from representatives of insurance carriers, providers, and other organizations. It was also suggested that you might consider whether the language in section 2 of the bill about the sort of one-time report that would be required, whether that's too specific to certain options that are outlined in the language as drafted. It was suggested that the committee might consider broadening the language to include specific consideration of some of the health insurance proposals that are being considered or have been enacted and are on the way to being implemented, like clear choice benefit designs, the potential merger of the individual and small group market, and other approaches within the health insurance market aimed at improving healthcare affordability and coverage. You did receive some testimony from Consumers for Affordable Healthcare suggesting that you consider adding a specific language related to the solicitation of public comment related to barriers to affordable health care. Their testimony noted that there is a provision in current law that requires the Office of Affordable Health Care to hold annual public hearings related to healthcare cost trends. And they suggested that you may think about adding specific requirement related to public comment on barriers to affordability, either as part of that public hearing or perhaps as a separate requirement. And lastly, this is just a suggestion to the committee if you are think you'd like to entertain it. It's not really related to the bill, but it relates to your confirmation hearings that you've been having for appointments to the Advisory Council on Affordable Health Care, whether or not you might consider amending the bill to address the confirmation process for appointments moving forward. As you know, as the law was enacted, it requires appointments made by the Speaker and the President to be members of the Advisory Council are subject to review and confirmation by the Senate. But the law requires those appointments to be made by the Speaker and the President. Typically, the legislature only reviews appointments made by the governor as part of the confirmation hearing process. And so this process that you're going through right now is a little unusual, given the separation of powers. And you may want to consider making a change sort of moving forward so that future appointments by the President and the Speaker for members of the Advisory Council do not have to go through the process that you're currently working through. And then lastly, we did get the initial fiscal information that any additional costs to the Office of Affordable Health Care if the bill moves forward can be absorbed within existing budgeted resources. And I will stop there. I'm happy to answer any questions.
Thanks, Colleen. Are there questions for our analyst? All right, I don't see any. Is there committee discussion? Also not seeing any. Okay, Representative Morris, go ahead.
Thank you, Madam Chair. I just wanted to point out the letter we received from the governor's office from Beth Bowe saying, I would agree with them. I think this is probably a little premature at the moment to be discussing this, doing this when the committee itself hasn't been fully formed and they haven't had any meetings to go over their, dealing with their current charge. And I would prefer to wait on something like this until, as the governor's office has indicated, there's a lot of work there to be done as is from the original statute. And I think it's a little premature to be considering adding new work onto the workload. So.
Thank you, Representative Morris. And I'll just clarify my reading and my conversation with the governor's office and my reading of the letter is that they're asking us to amend the bill. Not that they're not supportive of the bill, but asking for the amendment so that the report that's referenced in the bill would be due on January 1st or January 15th of 2024. But given the legislative cadence, if we didn't pass it this year, then next year they wouldn't have a work plan until after the year had already begun, so that there was a need for us to sort of get a year ahead. So that's my understanding of the timeline, and I'll turn to Representative Tepler.
Thank you. And I know that Representative Evans, who's the sponsor of the bill, is willing to go along with the governor's suggestion that we change that date, but we hope to pass the bill this session. And I am in favor of passing the bill this session. I kind of want this charge known by the executive director when he or she begins their work. even if it's not on the work plan for the first year he or she is in office. It's important to me that this idea is out there, because obviously the job of the Office of Affordable Health Care is to figure out ways to improve affordability.
Representative Evans?
Thank you, Madam Chair. And just to comment, I had discussions before we received comments from the governor's office. And one of the things that I was considering was pushing the date back, seeing as how this is a newly formed advisory committee, and we still have yet to have an executive director. My point being that we don't want to make this office, set the office up for failure. So pushing it back is not going to impede what we actually need to do. So I am more than willing to do that. There was another thing. The one thing about the confirmation process, I think that should be issued totally separate from what we're discussing in this bill. And I am not for including that at this time. And finally, as far as the public hearing process beginning in 2020, it says 2022, we want to push that out to 2023 as well. And as a part of the annual public hearing, this is already this language is already a part of LD 120, and we just wanted to add their cost reporting, a public hearing on cost trends and affordability barriers. The whole point is that we want to lay out a plan to look at cost and affordability across the board and give some guidance. And the committee will have that guidance with enough time to make reasonable calculations. If we don't move the date back, then you'll end up with a shoddy report, and that's not what I'm looking at. So thank you.
So I want to clarify, because I don't know if I heard it clearly, and I'm not sure Colleen heard it clearly, but I think the recommendation for the amendment is that in the second year of the cycle, we would add that word affordability barriers, but that we wouldn't change
Correct.
the requirement that there be a hearing in the first year. Colleen, did you understand that to be
I think that's right. Yeah.
the verbal amendment? Okay.
I think
Great.
that's what I understand Representative Evans would be suggesting.
Right.
So
Great.
we would just amend the statute so that beginning in 2023, the public hearing would ask for comment on both cost trends and affordability barriers. But the first year, October 1 of 2022, would just stay with the annual hearing on that date would focus on costs only.
Yes.
Okay. So I am gonna, just for the sake of discussion, I'm gonna make a motion for ought to pass as amended with a change in the date, and then that additional concept of affordability barriers being added to the public hearing in beginning in 2023. I think those are the only two amendments that are being proposed at this point to the bill. So I've made that as a motion. Is there a second? Seconded by Representative Matheson. And I'll now open it up for committee discussion on the motion. Representative Morris.
Thank you, Madam Chair. Yeah, I will be opposing the motion. I think this office was created, the idea as we understood it, as I understood it, was to get at the heart of what's driving costs in healthcare and trying to see what we can do to address underlying costs. And this bill seems to have a plan for what we're going to do going forward. which I think is we're getting away from the original mission when this was created, when this board was created, by putting in things to study around public options and Medicaid buy-ins and things of that I think is getting away from the mission of what we were asking this board to accomplish initially, which was to figure out what are the major cost drivers of healthcare, and then we can look at solutions later. But I think to bake solutions into this from the beginning is certainly not, I think, the right way to go. We should let the committee do the work first, and then we can discuss other options. So that is why I will be opposing the motion.
Is there further discussion on the the motion? Representative Brooks.
Yes. My thoughts on the office, the advisory council to the Office of Affordable Healthcare is that it's advisory, that there are people that come together with expertise in healthcare to advise about a system that is admittedly very nimble, especially with a pandemic and even before the pandemic. With healthcare, that's a very big topic. And in Maine, we've taken a proactive approach. And I appreciate, and my intent with an Office of Affordable Healthcare Advisory Council is to have a council that can work on these issues year round. And there are people that work on this year round, trust me, well, or not, trust me. But I appreciate the Honorable Dr. Evans putting this forward, and I'll definitely be supporting this.
Representative Tepler.
Thank you, Madam Chair. I would actually be open to the idea that there might be other methods, but I'm not sure what they are. So I guess I see the methods that are listed in the bill as being those that are most likely or most studied at this point. And I'm just curious what methods Representative Morris is thinking of that maybe should be included that aren't, and what his thinking is there about his objection to these 4 methods that are specified in the bill.
Representative Morris, do you want to address that?
Yes, I would be happy to address that, Madam Chair. My objection is that that this committee has not even met yet, and we're already saying that we want to look at these 4 methods for addressing this. We don't even have data yet from the committee from any studies that they've done, because they haven't done any studies yet. And we should wait until the committee does its work that they're currently charged with before we start coming up with plans for how we're going to address it. That is my concern. It's not whether or not something should be added or taken away. It's that this is putting the cart before the horse. We should let the committee do its work. And I mean, I certainly have not made any bones about my opposition to a government-run healthcare system, which I think is, we can say that isn't what this is, but that is ultimately part of the goal of some of this, creating public options and so forth. And so my objection is that my biggest objection is that the committee itself has not even had an opportunity. We haven't finished confirming everybody. They haven't been confirmed by the Senate yet. They haven't been seated. The executive director hasn't even been hired. None of the work has been done. So why are we now changing the charge when they haven't even started yet? I think that is my biggest objection to this bill at this time.
Thanks, Representative Morris. I'll just weigh in and say, again, I think we find ourselves as a legislature that only meets for 4 months in 1 year and 6 months in the next year, and then has to wait 90 days for laws to go into effect. So it's particularly important that we be forward looking and that we not just think about what needs to be done by the end of this year in terms of the Office of Affordable Healthcare, but what needs to be done by the end of next year to set us up for success. And that, I guess the other thing I would mention is that certainly as I go out into my community and talk to constituents, this is an urgent concern. And I'm not sure there's really a lot of confusion about what drives costs up. There's certainly nuances there about what drives costs up, but we as a committee have talked an awful lot about pharmaceutical costs and hospital costs and how fast they are rising relative to other costs in our system. Certainly we know that mental health reimbursement rates and physical therapy reimbursement rates, we've heard a lot about those as well on the other side, that they're not going up. And that could create access problems as well. But we do know what's driving cost increases. And so rather than waiting and sitting on our hands and then handcuffing ourselves going forward, I think at least my goal in supporting the Office of Affordable Healthcare in the first place, which I'm not sure was fully supported by all of the members on this committee. So I want to make sure that we're clear here as to, at least in my view, what it was meant to do was to continue to advance health reforms and push them forward, not just simply to create reports that would sit on a shelf and have no practical impact in terms of solutions for Mainers. So I think I'm very comfortable with us continuing to charge the Office of Affordable Healthcare with that important work on behalf of Mainers. Senator Brenner.
Thank you, Madam Chair. I also fully support Dr. Evans' bill and the amendments put forward. I think the handful of topics that are that we're directing the office to look into are nothing new in the public sphere of conversation around understanding what could happen with regard to healthcare being more affordable. Main care and Medicare both listed as things that we might want to look into. Those are existing programs, so it would be helpful for us to more clearly define what we would like from the Office of Affordable Healthcare as a legislature, as a committee who's been thinking about this issue for quite some time. And I think we owe it to the public to do everything we can within our power to understand as clearly as possible what might work on our state level with regard to what federal programs exist and how we can fine tune them on the state level, and then what we could do in an innovative way within our state to make it a better healthcare marketplace for our own residents. So I'm in full support of the bill that Dr. Evans has put forward, and I'm grateful for his work on it. Thank you.
Are there further comments? All right, Representative Arford, go ahead.
I'm sorry, I couldn't find. Yeah, I just want to state that I also support us moving this forward. I support the amendment. And I think that this is just in response to other comments, this is a brand new entity, the Office of Healthcare Affordability. And it was an entity that was voted into initially, was passed through to the floor to be voted into creation by our committee. And I think it is our responsibility as bills like this come forward to provide direction to this office in terms of initiatives which we think will be the most judicious use of their time in responding to their charge, which is stated very clearly in LD 120, which we created last year. So I would suggest that people go back to the original legislation, LD 120, and read again what that says about what this office is created to do, and then see how this bill put forward by Representative Evans falls in line with that. Because it is my opinion that it absolutely does fall in line with that. And so I will be voting in favor of this.
Okay, seeing no further hands, I think the committee is ready for the question, and I'll have the clerk call the roll.
Madam Chair, before we vote, can I request a quick 5-minute corner caucus?
Of course,
Thanks.
absolutely. We'll come back here at 2:10. Thank you.
Thanks.
If folks are back, you can turn your video on and we'll see if our colleagues have come back from their corner caucus.
I'm taking Doug for a walk.
Okay, it looks like our colleagues are back now. And so I will ask if they wanted to have any further discussion or if they're just ready to proceed with the vote. Okay, sounds like we'll just proceed with the vote. So I will ask our clerk to call the roll.
Thank you. Senator Sanborn,
Yes.
Senator Sanborn, yes. Senator Brenner,
Yes.
Senator Brenner, yes. Senator Stewart,
Senator, do we have a motion and a second on the floor? Oh,
Yes.
okay, sorry, excuse me. Go ahead, Edna, sorry.
that's okay. Senator Stewart,
No.
Representative Tepler,
Yes.
Representative Alford,
Yes.
Representative Blyer,
No.
Representative Brooks, Representative Brooks is absent. Representative Connor, Representative Connor is absent.
Representative Brooks will be back with us in a minute.
Okay. Representative Evans,
Yes.
Representative Matheson,
Yes.
Representative Malignano, sorry.
Yes.
Representative Malignano, yes. Representative Morris,
No.
Representative Quinn,
He said no.
No.
yes.
No.
No. Representative Quinn, no. Representative Brooks,
Yes.
Representative Brooks, yes. I have 8 yes and 4 no's, 1 absent. And Senator Stewart, what is your motion on the no?
We haven't actually caucused that, but I think we're good with ought not to pass. Is that correct, colleagues? Okay.
Yeah, ought not to pass.
Thanks.
Okay,
Thank you.
great. Thanks, everyone. Okay, so next we will move on to our next work session, which will be on LD 1798, an act to ensure health insurance coverage for certain adults with disabilities. And I will ask Colleen to provide her written bill analysis for us.
Sure. So here you go. This is LD 1798, as Senator Sanborn mentioned. The title is an act to ensure health insurance coverage for certain adults with disabilities. As it's drafted, it would require health insurance policies that offer coverage for a dependent child to cover adults with disabilities who are unable to sustain themselves through employment. You did have a number of pieces of testimony that came in on this bill, and a number of the pieces of testimony came in after the public hearing. So I did want to note that for the committee in there. It's all included at the link there. Under current law, I think, as most committee members are aware, insurers offering health plans subject to the Federal Affordable Healthcare Act that provide coverage for dependent children are required to continue coverage of adult children until the child turns 26 years of age. There is a corresponding provision that kind of predated the Federal Affordable Health Care Act in Maine law that requires individuals, insurers in the individual and group health insurance market in Maine are required to offer coverage at the option of the parent until the dependent child attains 26 years. So what LD 1798 is intending to do is to provide an opportunity to continue that coverage for those adult children after age 26 that because of a disability are unable to sustain themselves through employment. There were a few issues that were raised for the committee's consideration in the testimony at the hearing and in the written testimony you received. The bill as drafted refers in the definition of disability to as sort of a condition of qualifying that the person be unable to obtain self-sustaining employment. And it was suggested that the committee consider whether or not that term needed to be further defined, or whether the definition of disability needed some further clarity. It was also suggested that the committee think about the relationship between coverage that may be currently available to families with adult children with disabilities through to provide services through Maine Care waivers, and what may be available through private health insurance coverage. It was suggested in the testimony that while the scope of services available through private insurance may be more limited than what's available if someone qualifies for services under one of the Maine Care waivers, the potential reimbursement to providers under private insurance may be higher, and the coverage that would be made available by the bill could potentially fill gaps that families are experiencing while they are waiting for Maine Care waiver services. It was also suggested that the committee may think about whether or not the bill is necessary. You did have some testimony from representatives of insurance carriers that coverage may currently be available beyond age 26 under existing policy contract language when the dependent has documented disability. The committee did ask for some more information on that point, and asked for some examples of some of the contractual language and some testimony that Community Health Options filed. I provided it here as an example of what they include in their contracts. They do allow this extension or a continuation of coverage, and their contract language says that someone qualifies if the dependent is an unmarried child of the subscriber or the subscriber's spouse or domestic partner who, as of the date the child turns 26 or older, is mentally or physically unable to earn his or her own living and is chiefly financially dependent on the subscriber. So if the committee moves forward, we might consider thinking about sort of if you are amenable to this type of language, sort of redrafting LD 1798 in a way that might more closely align with some of the existing contract language that's being used now. Concerns were also raised about whether the bill might have a premium impact, particularly in the individual market, because it would be a a decision that would be made on an individualized basis by a family as to whether or not they would continue coverage for a dependent, and then have to, they'd have to price that and pay for that coverage. The Bureau of Insurance's testimony that you received suggested that perhaps the committee think about amending the bill as an exception to a carrier's right to terminate coverage at age 26 and maintain coverage for dependents with disabilities. But the question was also raised how to address policyholders that might change carriers or obtain new coverage, move to existing carriers, and the committee to different carriers. And the committee did ask that the Bureau of Insurance take a look at that issue and maybe suggest some changes in language to address that. The Bureau has suggested some potential language to sort of redraft the bill instead of thinking about it as an extension of coverage, clarify that it's an offer of coverage that would be made if a carrier provides dependent coverage as part of their package that's available to their policyholders. Then at the option of a parent, they would be offered this type of coverage for someone past age 26 if they have a disability, and they would be required to provide that coverage at the parent's option, regardless of age. So I do have some suggested language if the committee is interested in taking a look at what the Bureau has come up with, making really some slight changes to the language of the bill to make that point a little clearer. The last thing I would note, sort of from a drafting or technical perspective, is as the bill is drafted, it's drafted as an emergency. And so if it were enacted, it would take effect on the governor's signature. As we talked about with prior bills, with health insurance specifically, the committee often will amend language such as this to provide coverage for a specific application date. That's usually when the committee is sort of mandating changes to coverage in terms of benefits or the terms and conditions of a contract. This is not necessarily the same issue here because it's a mandate to the insurers that they offer coverage to a parent. But if there is a need to sort of amend their existing contractual language, the committee may want to consider thinking about a specific application date. And then just lastly, which I think was brought up at the public hearing, there are 40 states that require some sort of offer of coverage to adults with disabilities for state regulated private insurance. And again, to remind the committee, under Maine law, our changes to the health insurance code or the insurance code apply only to private coverage. It would not make changes to Medicare, Maine Care, federal ERISA plans, self-insured plans under ERISA, or any federal employee benefit or other federal plans that would cover sort of military members, active and retired. And I'll stop there, and I'm happy to, as I said, if you'd like to take a look at sort of the Bureau suggestions, happy to share those at any time as well.
Thank you, Colleen. Are there questions for Colleen regarding her bill analysis? Representative Tepler.
Thank you, Madam Chair, and thanks for that analysis, Colleen. Ms. McCarthy-Reed. Can you tell us whether the Bureau's language says that they must make the offer?
Yes, it does, which is what is consistent with the original bill. The language would essentially sort of make some changes to the original bill and say that if a dependent child has a disability, the policy must offer coverage, and consistent with how the existing provisions in law work for an offer of coverage to a sort of adult child up to age 26. It would require individual and group health insurance policies that offer coverage for dependent children must offer such coverage at the option of the parent or the policyholder in the case of an individual policy for a dependent child with a disability regardless of their age.
And would the rate for that offer be set by the Bureau of Insurance?
There's no specific reference in this the bill to the rate for that coverage. It would just be determined as rates are determined now under the existing statute for coverage. So the Bureau does have oversight over insurance rates, and their existing oversight over rates wouldn't change in this instance. The bill makes no changes to the current law with regard to that. It would allow insurance policies to rate on the same basis that they can do it now for coverage up to age 26, for instance.
Thank you very much.
Representative Morris.
Thank you, Madam Chair. Is the language of the bill or the amendment from the Bureau clear on that the coverage would be a continuing coverage of somebody who's reached 26 years old? In other words, that it's the coverage was already there for that person with the disability prior to age 26, for the disability purposes. Is that made clear with this bill?
I think so. It might make sense for me to share it so folks can see it. Would that make sense?
Yeah.
You pull it up and so I'm pulling it up what they have suggested now. And I'll just use this first section, these first two sections as an example. If the bill makes sort of the same changes in a number of places because we're amending the law that relates to individual policies and also to group policies. But this is the existing law right now that requires individual health insurance policies that offer coverage for dependent children up to age 26. And so we're adding language to that here, this last sentence that says, if the child has a disability, the policy must offer coverage in accordance with, and then it refers to the new section that's added by LD 1798. And you'll see in red sort of the changes that the Bureau has suggested to address this issue about, in part, I think it addresses the issue to both cover a continuation of coverage or also a situation where someone might switch coverage. But it removes the reference to extension of coverage and would just say that individual health insurance policies that offer coverage for a dependent child, and that's something that you should be aware of. It doesn't require insurers to add this to all of their policies, but if they already provide coverage for dependents, they have to provide this coverage for a dependent with a disability regardless of their age. So that's what this new subsection 2 would say. So individual policies that offer coverage for a dependent child must offer coverage at the option of the policyholder or the parent in the case of a group policy for a dependent child with a disability regardless of their age. And it keeps the language in the original bill that requires documentation or proof of a disability to be provided. And then this,
Thank you.
The next sections
Okay.
carry forward the same.
Great. One of the reasons I think this is such an important bill, I will just jump in and say, is because we have designed our health insurance universe largely to be an employer-based health insurance world. That's really how most people are expected in our economy to get their health insurance unless they qualify for main care. And so as long as that's the case, and we have an adult population that is unlikely to get that type of employer-based insurance on their own because of their disability, I think this is a really fair way of reshaping the rules a little bit to be more humane and to better reflect the economic realities that families are facing
And I'd love to have a consistency. I know there's some inconsistency now with regard to whether the disabled adult child has to be unmarried, for example. And we know that there are a lot of folks who can't support themselves, but who may want that right to be married and need to still be able to access health insurance through their parents. So I'd like to be able to provide this consistency in Maine law as 40 other states do. Representative Brooks.
Excuse me. So I think this is a really important initiative, and coordinating care this way really has great potential going forward. I do agree with the intent behind the bill to make it and transition processes for people that have disabilities to have continuity of care, continuity of coverage for a reasonable amount of time. With strains on our current system, like as far as in a lot of areas, I do think it's really critical. It's just very important, and I do support this. And one concern I have is to make sure that if a juvenile, somebody on their private insurance policy, and the ones that we regulate specifically, if they if the family is in a situation where, and somebody may or may not qualify for certain benefits as far as healthcare insurance, and that could be fluctuating. So yeah, I would love to see a situation where there would be that continuity of coverage, continuity of care, and then also the reimbursement situation was mentioned in the testimony. And I think that it's important that we have more continuity and ease of access for people. The question I have is like, how do people see this? Whether Colleen can talk about it more, or Superintendent Chopper or somebody else, how do they see that potential? And is there any way to make that process within the insurance realm smoother? And does this go, where did we land on the language of the compromises after? Because I think the language is important, and yeah, that would be helpful for me.
Okay, I think Colleen just showed us the language with regard to making sure that this covers the situation where somebody might have changed jobs and have a new policy. A parent would change jobs and have a new policy. So I think that's appropriate. I don't know if that answers your question, but I'm going to move on. Representative Morris, is your hand old, or did you want to speak again?
No, yeah, I just want to speak again. I wanted to state.
Okay, go ahead.
I do agree with what you said. I think this is an important bill. I've had family in similar situations, so I absolutely agree. I just wanted to make sure that that the coverage is continuous coverage of somebody that was on an insurance that would have been qualified for an insurance plan before they were 26, I think is really what I was after. And I'm certainly satisfied with Colleen's answer. So in other words, that the coverage was that they were covered or would have been, because I understand people change jobs and all of that before 26, that it's not a new occurrence of somebody. I think I'm satisfied with the answers, so we're good.
Okay, all right. Well, we'll move on because I'm not sure I totally understand your question, but if you got it answered, then I would like to move on.
I think what I was after was if someone who has a documented disability before 26 being able to have continuous coverage after 26 is what I was after. That the disability was documented before, that it's not a new disability after that age of 26. That we're looking to, in other words, cover someone who was covered before the age of 26 with a documented disability. I think that's what I was after for a question. That's the question I was after, not if someone was on an employee-based health insurance or wasn't, and then all of a sudden
okay, so your concern, Representative Morris, is that if somebody is 29 years old, gets in a bad car accident, and now is let's say quadriplegic, back home living with mom and dad, you would like to make sure
Well,
that they don't have access to
well, no,
employer-based health
I don't
insurance.
think
Is that
that's
right?
really what no, that's not necessarily, I think we're just looking to make sure, no, I don't think that's what I'm after. I don't think that would be the right
Okay.
plan. I mean, I would hope in those cases, what we're after is making sure that person that's 26 that had the documented disability beforehand is able to continue their coverage is the goal of this, is my understanding.
Okay.
No, but I understand your situation there, and there are all kinds of different situations, and I would not want that situation to put that person in a position or put their family in a position where they could, because there are not a ton of those situations. So that I thank you for clarifying my point.
Okay. All right, I'm going to move along, and if we need to circle back, we can, definitely. Representative Arford, go ahead.
Yes, thank you, Madam Chair. I certainly support the policy of this bill. I'm a co-signer. I think it's an idea it's time to implement it in legislation. However, I'm not sure I fully understand who will be making the final determination of what disability is. What I understand, what the bill tells us is that the parent member will apply for their dependent adult child to continue past age 26, and they will have to provide some proof that that child is disabled. But who will decide whether or not it's an adequate disability? Will the insurer decide that? Are we going, one of Colleen's thoughts that she shared with us, that we might look at how we are defining disability? I just do not want to leave. My concern is I do not think it would be a judicious part of this bill to leave it up to the individual insurance company to decide whether or not the individual is disabled. I think we need to have a standard that's met across the board by all the insurers. So there's no ability for them to deny coverage based on their own definition or their own determination.
Yeah.
And I'm not
so,
sure we're aware of that.
So there is a definition of disability in the bill. So I guess I could have Colleen share that. And then I guess I would ask Colleen to just give us a really brief review of how the appeals process works if the insurer were to take that language that's in the statute and say, you don't meet that standard. What would the appeals process for a consumer be in Maine law?
So that, as Senator Sanborn said, there is a definition suggested in the law or the bill as drafted, and it defines a disability as a physical, intellectual, or developmental disability that renders a person incapable of self-sustaining employment. That's the definition. You did have an example of a definition or a standard that's used by another insurance carrier, which differs from this slightly. But so you could consider amending the definition, but that's the statutory standard. As you mentioned, Representative Arford, the bill as drafted would require the enrollee to provide proof of that disability to the insurer in writing if they request it. Within 31 days of the time the child attains the age 26, if they're going to continue coverage past age 26, and subsequently as the insurer may require, but the requirement to provide proof is limited, and it says the insurer may not require proof more frequently than annually after the 2-year period following a dependent child's attaining, age 26. So there is some parameters in terms of how often an insurance company can require documentation related to the disability. And as Senator Sanborn mentioned, there are processes in statute for appeals to be made of certain decisions. I'm not sure that the sort of, maybe the Bureau can weigh in on this because it's not an adverse healthcare treatment decision. It's more of an eligibility decision. So I'm not sure that the exact, timelines apply related to grievances of, denials of care, for instance. but I do believe that under the existing law, a policyholder or an enrollee would have an ability to seek recourse through the Bureau of Insurance if they felt that an insurer was denying their eligibility for coverage under the statute or misapplying the requirements of the law.
Thank you. Representative Tepler.
Thank you, Madam Chair. I have two questions about eligibility under the definitions we've been discussing to make sure that they are broad enough to include the situation that we were discussing with Representative Morris, where an adult child has a sudden severe injury, regardless of type, and is then no longer able to have self-sustaining employment and becomes a member of their parents' household. Are our definitions broad enough to cover that scenario? And the other concern I have is about severe mental illness. If your child is schizophrenic and requires them to live at home and be monitored on a regular basis, does the definition that we've written in the law cover severe mental illness as well?
I think as to your first question, I think the way that the language is drafted, it talks about providing an option of coverage for a dependent child with a disability regardless of age. And the definition of what a dependent child is the child of a parent that is covered under an individual or group health insurance policy. So I think in the situation where somebody might have a disability that would qualify after the fact, the language, as I look at it, I don't think would limit that or prevent that from happening. But again, it goes back to the definition of a disability too. And I'm not sure that the definition as it's currently crafted, where it talks about a physical, intellectual, or developmental disability, would cover someone with a severe mental illness like you mentioned, Representative Tepler. I think it's focused on
physical and intellectual disabilities.
Yeah, and developmental disabilities, which to my mind, would be things that would be present, from a very early age. It wouldn't necessarily be, doesn't necessarily specifically refer to mental illness, for instance. So I'm not sure it addresses that situation. There may be other provisions in the statute in current law or situations there in terms of qualifying for other types of public coverage, in that situation. But I'm not sure that this statute would govern that, or this proposed statute would.
Yeah, I have some concerns about that, but we can revisit.
I wonder if we shouldn't add the word mental because or behavioral, and the reason that I say that is because I think some of the other language we looked at doesn't include the words physical, intellectual, or developmental. It just says disability, and I think maybe the CHO statute or contract language just says disability. And so if we're going to list them, we want to make sure that we're listing them in a comprehensive manner. Because certainly I think this committee has been quite committed to mental health parity and to the idea that mental health conditions are just as real and severe as physical health conditions. So I don't know, I guess I would take Representative Tepler's comment and suggest we add the word mental after the word physical. But that's just sort of throwing that out there on the floor as a potential way of addressing that issue, which I had not thought of until just now. Representative Quinn's hand was, go ahead, Colleen.
Oh, I was just going to say the community health options, contract language talks about mentally or physically unable to earn his or her own living and is chiefly financially dependent on the subscriber. So that may be something where you might want to think about sort of meshing kind of what's in the existing proposal in LD 1798 with some of that contract language to, I think if you did that, you would bring in individuals with, the mental illness that Representative Tepler described and was interested in providing an option of coverage in that situation.
Representative Quint.
Okay, so my question is just about the dependency. Is this where they're actually living at home with their parents, or is this supposed to cover even if they're not under their parents' roof?
Under the existing law that provides coverage for adult children up to age 26, there's no requirement that they be living under the same roof as their parent now. So the bill as drafted doesn't make any change related to that either. So it could be situations where they are not living at home, but have dependents or under the existing, the CHO language that I just mentioned, it talks about financial dependence, doesn't necessarily mean residing with the parent.
And is that coverage even like if they're not away at university or not enrolled in college now?
Under the existing law, yes.
Representative Evans.
Thank you, Madam Chair. I just want to follow on. I think Representative Tepler makes a good point. I think if we can mesh in the concept regarding mental health, I think that this would be the opportunity to do that. So I favor doing that.
Yep. Okay. Representative Brooks.
I also strongly agree that we need to consider the whole person, and that the medical certainly is part of the body, and it's so interrelated that it's hard for anyone, even with expertise, to really parse out, what came first and how it's interrelated. And some things may not manifest or may manifest differently at a very young age than they do when somebody is, say, a teenager or 23. Yeah, and so I think it's really important to have a parity frame.
Okay. Are there further questions or comments? Okay. Representative Arford, go ahead.
Just one final thought. Based on the response that Colleen gave to us in terms of a potential appeals process, I still have the concern that unless we set an actual standard that will be held across all insurers, that some insurers will make it very onerous for a member to show proof that their dependent is disabled to the degree that they would qualify for ongoing coverage. And so is there a way to at least somehow connect the dots between, if that does happen, what recourse the member would have to take action and, to advocate for themselves?
Well, so I guess Representative Arford, the only thing we can do to set a standard is to put clear controlling language and definitional language into the statute. And it's my opinion and my belief that we've done that in this bill. And then we've had this conversation about adding the word mental to make it even clearer and more comprehensive. But then if a insurer looks at those words, right, because these are all just statutory words, if an insurer looks at the words and goes against them, then that insurer is violating the law, and the recourse would be through the Bureau of Insurance, or frankly through the courts if you're violating the law. But generally speaking, our insurers are responsive when the Bureau says to them, hey, you're not doing this correctly.
but the standard is the words in the law. And unfortunately, we can't get any better than words, and words stink. And I'm sure Senator Stewart in his law school classes has figured out, as I did in law school, that, you know, the English language is terribly insufficient to be clear and to have us all always on the same page, but it's still the only way we know how to make laws. So I think what we've done here for a disability definition is really the best we could do. We can wordsmith it more if there's a word in there that we think is vague or unclear, but I don't find them to be vague or unclear myself. So, so I guess I would invite you to offer, if there's a particular word in our definition of disability that we're working with that is not clear on its face, then we could try a different word, but ultimately we're going to be limited to trying words.
Well, thank you so much for that response. That was very thoughtful, and I do appreciate it. I do know that for our insurance policy, because of situations in my own family, I have spoken to them about this previous to this bill, that they have coverage for what they consider, they call them incapacitated children, and that coverage will extend past the age of 26. This is in the state, our state employee that we get as legislators. And I think part of the requirement is that 50%, they actually use the standard of 50% of their expenses, their living expenses are provided by the member, by the parent member of the insurance policy. And I'm not suggesting that we put that in there. I'm just saying that would be the type of standard that I'm talking about. Either you can prove you provide 50% or you can't, versus just the standard of the person cannot sustain employment, I guess it's self-sustaining employment. That's a very broad standard. So I don't want to belabor the point. I just felt it necessary to express my thoughts on this. So I'll leave it at that.
Okay, Representative Brooks.
Yeah, I think some possible suggestions with, and I think a lot of this could be rule information, but I mean, the experts in the room can help us with that, and Colleen can help us with this. But one possible compromise or suggestion may be to say, to get more educational materials, like if there's a particular rule change, and we've made a lot of advances that way, but if there's a particular situation where, let's say somebody is 22 and they're insured by their parents' insurance policy that we have jurisdiction over, and something happens to them or their heaven forbid loved one who is covering them in the insurance policy, how do we provide some protection in a comprehensive way that the dependent child has coverage, disabled child has coverage in the event that something really terrible happens? And so I think if there was some sort of a language about the duty to inform both the person that's the insurer and the disabled child, because the spectrum is really broad, so that perhaps there could be language about the duty to inform both parties or something. I'm not sure, but perhaps there's some sort of possibility there.
Okay. Are there any other comments? All right. I don't see any. What is the desire of the committee? Do we want to have a motion and go forward with a vote? Do we want to table this and get some additional language? What's the desire of the committee? Representative Matheson, excuse me, Matheson.
I'd like to make a motion with the amendment of mental health addition, but that would be where I would be moving.
Okay. And certainly we can still table it even if we have a motion on the floor. So do I have a second for the motion? Senator Brenner, I saw your hands go up first. So we have a motion ought to pass as amended. I think it would be the amendment, if I'm understanding, Representative Matheson would be the one proposed by Colleen, but with the additional language of the word mental in the definition of disability everywhere that it appears.
That's correct.
And I'm seeing a nod from the folks who made the motion. Okay, so that's the motion. And so I will next call on Representative Morris.
Yes, I was actually going to move the table so we can look at some language, look at the language when we get it back before making a final vote. So I moved the table, sorry.
Okay, so a motion to table is not debatable. And so since the motion has been made, we will, pardon me, just take the vote on the tabling motion without calling on additional people. And our process here has been not to use a roll call, but just to use our physical hands in the window for tabling motions. So I would just ask if you would put your physical hand in the window so that we can all see it to determine whether it's unanimous vote to table. So please raise your hand if you're in favor of the motion to table the bill at this time. And I see all of the folks present have raised their hands. So we will consider the bill tabled, and I anticipate that we will bring it back in our work session on Tuesday. And I feel comfortable doing that. Colleen?
I was just going to say I can redraft it in accordance with Representative Matheson's motion and share it with the committee tomorrow. So you'll have and the interested parties list, so folks will have time to take a look at it before Tuesday's work session.
That would be great. And Representative Quint, we've closed we tabled the bill, but if you have any requests or additional information you need, I think that's fair. Go ahead.
Thank you very much. I just have a question as far as mental disability, because I know Representative Tepler had brought up like a severe mental illness that would incapacitate someone. And I'm just making sure that that's not something along the lines of like a period of depression where they're constant, where they're working through a temporary issue. That they then stay on permanently afterwards. Do you know what I mean? I completely am in agreement when you have like bipolar disorder or, yeah.
Yeah, Senator Brenner, go ahead.
Point of order. I think Representative Quint is launching into further discussion after the bill's been tabled.
Sorry. I just wanted clarification of what that was, I guess, when it comes forward again. Do you know what I mean?
So we can definitely talk more about that when we bring the bill back, and I certainly invite you to talk to folks in the interim as well about what the implications might be there. But I think Senator Brenner is right that we don't actually have a bill that we're working at the moment. So I think we'll move on from there. All right, great. Well, I'm just waiting for my screen to reload here so that I can read the next title. So the next bill is LD 1815. This is an act to revise certain financial regulatory provisions in the main insurance code to be consistent with model laws from the National Association of Insurance Commissioners. And I'll ask Colleen to go through the bill analysis.
Sorry, I had to unmute myself. So this is a bill that the Bureau of Insurance brought forward. It seeks to amend a provision of the insurance code to enact the most recent revisions to the NAIC, which is the National Association of Insurance Commissioners Holding Company Model Act. And these changes establish a framework for group capital calculation and liquidity stress tests for those holding companies, and also provide additional safeguards to ensure the performance of contracts between a domestic insurer and its non-insurer affiliates within that sort of holding company structure. The bill also provides a uniform definition of the NAIC in various places throughout the insurance code, and also make some changes to set up a sort of consistent framework for controlling access to confidential information within the Bureau of Insurance when they engage outside contractors. So it puts in place some parameters for when confidential information is permitted to be shared under the law currently, with outside contractors what their obligations are with regard to that confidential information. As I mentioned, the bill was brought forward by the Bureau of Insurance. They noted really a couple of reasons why they believe the changes are necessary. The changes related to the group capital calculation that reflect the updates to the NAIC model are necessary to have in place this year, so that Maine law governs the capital standards that are applicable to our domestic insurers, and one of which is the Unum Group. And this will allow Maine law to govern, as opposed to covered agreements with the federal government and the United Kingdom and the European Union would allow those entities to impose their own capital standards on the Unum Group as a condition to doing business there, unless these changes are adopted. The other changes that are included in the bill reflect updates to the model that would be necessary for Maine to maintain its accreditation by the National Association of Insurance Commissioners. And then there are other changes that, while they have not yet been adopted by NAIC as accreditation requirements, the Bureau does anticipate that NAIC will consider them and adopt them, and the NAIC in their guidance has recommended that states consider making these changes as appropriate. You did hear from Mr. Garrity on behalf of the American Property Casualty Insurance Association, who suggested 2 additional changes to the bill as drafted, based on some language that was included in the NAIC model. One is to add some specific language stating that the group capital calculation, the group capital calculation ratio, and the liquidity stress test requirements may not be used as a means of ranking insurers or insurance company holding systems. That was something that was removed from the draft in the drafting process by the revisor's office. I think really because of a technical issue. So I think if the committee does move forward and wants to include that language, I would just put it in a different place than was suggested by Mr. Garrity, just to be consistent with our drafting standards and formatting. And then secondly, Mr. Garrity recommended that a provision in the existing law, which relates to confidentiality of certain documents, add specific reference to clarify that holding company information is proprietary and trade secret information. The current law already designates that information as confidential and not a public record. So this would be an additional section of law if you're interested in moving forward with that. I would just note that the current statutory framework for confidentiality, designating information as confidential, already recognizes proprietary and trade secret information as sort of a subset, or sort of a factor that qualifies as for designation as something being confidential. So the current law already designates the information as confidential, and if the holding company can assert that the reason why it is confidential is because it's proprietary and trade secret information, I think it may already be covered in the existing law. I don't think it changes anything substantively if you included those additional references. But I would just note that, and if you do move forward, as we've talked about it before with regard to designating information as confidential, it undergoes an additional review by the Judiciary Committee for creating new exceptions to public records laws. There is an existing provision in Section 17 that designates documents related to the group capital calculation and liquidity stress test as confidential. So that would require the bill to go through that judiciary review process. I think they would also take a look at the suggested change that Mr. Garrity has made related to adding sort of the references to proprietary and trade secret as well. And just to that point, I would just note that the Right to Know Advisory Committee, which is an ongoing committee that reviews existing public records exceptions, has been undergoing an effort to make the current law consistent in how it refers to and designates information as confidential. And their recommendation to the Judiciary Committee this session is that the statute or throughout the statutes make consistent reference and use the phrase designating information as confidential just to say it's confidential, and it's not necessary to use those additional words like proprietary or trade secret. So I just flagged that if it does move forward, that may be something the Judiciary Committee may raise with the Hcifs Committee with regard to that proposed amendment. And then the last thing I would note is the bill as drafted would take effect 90 days following adjournment of the second regular session. The statutory adjournment date is in April, and the anticipated effective date then would be sometime in July. I would just note that you did have some testimony that was submitted in writing from UNUM indicating their belief that for the need to have these changes in place no later than September of 2022. I just didn't know if because of that, the committee might consider adding an emergency preamble and emergency clause so that the bill, if enacted, would become effective once signed by the governor. That would require a 2/3 vote, but it may provide some certainty as to having it go into effect before that September 1 date. While statutory adjournment is in April, I think, as you all know, sometimes that doesn't always happen, and there have been circumstances where legislation has been enacted with an anticipated effective date based on 90 days following statutory adjournment, and that hasn't necessarily always been the case because of delays in adjourning the legislature. So I just raised that as a potential additional issue for you to consider. And we don't yet have any fiscal information, but because it's a Bureau of Insurance bill, I anticipate that any additional costs can be absorbed within their existing budget.
Thank you, Colleen. Representative Evans.
Thank you, Madam Chair. I was hoping, Colleen, that you'd leave your screen up. There was one on the page before the last page where there was a suggestion to the previous page.
There we go.
Okay. And you said that Mr. Garrity was suggesting that we move that, include that language, but you suggested moving it to some other place.
Mm-hmm.
Where would it be put?
I would just, my suggestion would just be, he suggested adding it to an existing paragraph F in the bill, and I would just make it its own, its own individual paragraph.
Okay. All right. Thanks.
Yeah.
Thank you, Madam Chair.
You're welcome. Representative Tepler.
I'd like to put the Bureau of Insurance on the spot and ask them if they feel that Mr. Garrity's suggestions make a real difference in the protections for his association.
Okay. Could someone from the Bureau raise their hand as to who wants to address Representative Tepler's question? Come on, one of you has to. Okay. All right. We'll bring over.
Oh, everybody's doing it now.
They're not in the same room together, so they were probably waiting to see who put their hand up first. So we'll bring over Mr. Wake, who put his hand up first, and Mr. Yardley just put his hand down. So there we are. Good afternoon, Mr. Wake. When you can hear us, you can unmute and go ahead.
Good afternoon. We looked at these provisions, and as was discussed, the language about the group capital calculation liquidity stress tests not being a method for ranking insurers was included by the NAIC as part of this paragraph F as the reason why companies aren't even allowed to waive confidentiality and publish their own GCC and LST results. We've got a similar precedent in the risk-based capital chapter, which I think is the 6700s or so, and for similar reasons. And when we presented this for redlining, the reviser basically said, pull it out because Maine doesn't put in findings and rationales when it when it enacts statutes. And so we have no problem either way with including it or excluding it. It doesn't affect the substance. So we were fine with Mr. Garrity's amendment if he wanted to proceed with it, but we don't see, and I'm not sure whether he sees it, as something that actually changes the protections that are provided either way. I will have to say that if it doesn't go in subsection F, then in paragraph F, I'm not sure where a good home would be, but Mr. Garrity and I could work that out.
Thank you.
So Mr. Wake, sorry, Mr. Wake, can I just see if I can get clarification on that? So in your understanding, the confidentiality of those capital reviews and stress tests is already so thick that there is no need for the additional provision that Mr. Garrity is requesting, because you couldn't publish such a rating because you can't disclose the information, period, full stop, in any capacity. And so no one would be able to put that rating together, even the insurance company themselves that was at the top of the heap.
Well,
did I summarize that correctly?
Somewhat. And
okay.
there is one exception, which is insurance companies, as with risk-based capital reports, can use it to rebut misleading comparison by a competitor or an analyst, or a false statement about their, so that's in there. As for the proprietary and trade secret, I think that was also initially left out because of it was really the rationale for why is it confidential? Why is it not subject to subpoena? But again, we agree that that is a valid rationale for this purpose. So if it doesn't get us into trouble with judiciary or with the Right to Know Advisory Committee, we're we are basically okay with whatever works, because we agree with the substance. We don't think it's necessary. Mr. Garrity thinks it might be necessary. We spoke with people from trade associations who helped draft it for the model, and they basically said they were responding both to the need to deal with 51 different statutory schemes in 50 states in the District of Columbia, and also with hypothetical scenarios. They weren't sure exactly where it might be helpful. And that's, I think, also a concern Mr. Garrity raised.
So,
but I can't speak for him.
So, Mr. Wake, part of what I also heard from you was that stylistically, the way that Maine codifies law, it doesn't generally include this kind of piece, which could be considered a rationale.
That's correct. That's why the reviser pulled out the language I drafted on this isn't a means to rank insurers.
Okay.
The other piece wasn't on the table this year, but I think it was a similar rationale why it wasn't included back in 2013 when we drafted the original existing language.
Thank you.
Okay. Are there any additional questions for Mr. Wake? All right, I'm going to send him back through the wormhole.
Bye.
Mr. Wake. Mr. Garrity has his hand up. I will bring Mr. Garrity in. Hi, Mr. Garrity.
Hi,
Go ahead.
Sam. Thank you for bringing me in just for a moment. The rationale piece that, as it was explained to me, was of concern to the revisor's office, dealt more with the way that that I drafted, or that the NAIC model had it drafted in the first place, because when it mentioned ranking insurers, it said is not intended to be a means to, which is a statement of rationale. I took that as not intended to be out, which got us past that, the rationale issue, and to the straightforward statement that it is not a means. So that's a legislative directive, and I think it gets us past the concern that the revisor's office raised, although Colleen could speak to that if she thinks that's still a problem. I don't really feel that strongly based on the discussions I've had with the Bureau since the public hearing about the trade secret / confidentiality piece. I think their point, once we had a chance to talk about it, was well intended or works well. As to the ranking insurers piece, we still urge the committee to put that in. I think it was a boots and suspenders provision that was put in by the model. That's my understanding. At the same time, we see no reason to allow any of these data to be used and part of any analysis that ranks insurers in any way. And the fact that Bob mentioned that there are ways to rebut misleading statements and the like suggests that there could be situations where ranking could be an issue. So it is part of the model. We do believe it serves a valid purpose. The Bureau is not opposed to it. We don't have a problem with moving it to a different section if Colleen wants to, and I'm happy to work with Bob if the committee's inclination is to keep it in. So we'd urge, particularly on that first proposed amendment, that the committee keep it in. And I appreciate you bringing me in, Senator.
Sure. Okay. Are there any questions for Mr. Garrity? All right, I'm going to send you back. Representative Brooks, is your question for Mr. Garrity?
Actually, I had a question that might relate to both Colleen and Mr. Garrity and the committee moving forward on this issue in the Bureau. But should I say?
Why don't you go ahead and why don't you go ahead and hopefully Colleen can address it so we don't have to pull Mr. Garrity in again, because I didn't see your hands. Okay.
Right. I was kind of hoping Colleen could pull it together as well. So because the answer might be right here. So a couple things in that more historical perspective. I would love to have, like, I think the whole consideration of confidential versus proprietary and trade secret makes a difference to me anyway. Like if it's medically confidential, I agree that that needs to be confidential and it can't be revealed. But if it's proprietary and trade secret, that does give me more information as far as, is it in the contract or is it, we don't want to reveal the identity of the person. So I mean, that does kind of make a difference to me. For I don't know if Colleen could address that, or if that's more of a committee level discussion. And then the other thing that came to mind was with an NAIC proposal, I think that our insurance companies that are Maine-based or small, locally based insurance companies, I think it would be potentially beneficial that if something, and I think we have a process for this as well with the Bureau and other investigative arms that are not necessarily needing to be public, but to respect the right to know, is how do we address the potential of like the right to know and the information, like say an example is the recent coronavirus. In Maine is a relatively small state. Some places are smaller than others. But how do we address that kind of fine line between And this does a good job at NAIC. They know better than me, and the Bureau does as well. But that's another thought is we want to have the ultimate protections geared towards the potentially disabled, the potentially consumer level person, covered person.
Okay. I'm not positive I understand the question. Colleen, do you understand any?
I'm not sure I follow it completely either, but in terms of like proprietary and trade secret, as I view it, is sort of, as we talked about it before, it's sort of a rationale for why information might be designated as confidential. So that's why I think the reference to those terms, if something's already designated as confidential, it's really not necessary to say that they're also proprietary and trade secret information, because you've already protected the disclosure of that information. So I think that's partly why the original, the language in the original law just left it at confidential and didn't include the additional reference to something being proprietary or trade secret. But there are lots of other reasons why information might be designated as confidential, like you said, not disclosing someone's identity or personal medical information. And so there's sort of lots of other reasons why the statutes in Maine might designate certain information as confidential. Proprietary and trade secret is one element of why things are made confidential, particularly with regard to regulated entities like insurance companies.
Great, that's really helpful. Thank you. And that was one, yeah, it was kind of a two-pronged question. And I did hear somebody say something like the insurance company can't kind of like reveal their statistics overall, but I wondered if there was a way, and maybe it's already through the Bureau, or would go back to the Bureau. But the thought was with the second point or second question had to do with, let's say that there's a complaint, and again, it would go through the process that we have in place through the Bureau and through the insurance company, as far as an adverse decision on the part of the person. There's a appeals
Heidi, I'm
process.
going to interrupt.
Okay, you
Representative
stop.
Brooks, I'm going to interrupt you because I think you're mixing up a couple of different bills at this point that we've talked about today. So we're talking about reviews of insurance companies at sort of the capital sufficiency level right now, and that's really, really different than the other thing that we were talking about. And I think those are getting mushed together. So I want to try and make sure we're staying pointedly talking about this particular bill and the issues that are at play in it. I think the only question on the table really is whether we would like to amend the draft to include Mr. Garrity's first suggestion, because I think he has backed off of his second suggestion. And so I think the question for the committee really, and I guess it's a motion that we could entertain, is which direction we want to go with regard to inclusion or not including that language regarding ranking of insurance companies. Representative Tepler.
Thank you, Madam Chair. And I think my concern is that we make sure that the language of the bill is in keeping with the format of codification that the revisor's office expects. So including some of that language without making it a rationale, I think would be the way to go. And I think there's a way to wordsmith that. Colleen, I can see you nodding, so you obviously agree. So I would I would make a motion ought to pass as amended with a change that incorporates Mr. Garrity's first set of concerns, as long as we can meet the codification standards of the Maine statutes.
I think that's doable. Is there a second for that
Yep.
amendment?
I'll second.
Representative Morris has seconded. Okay, and Colleen, can you just verify that that's draftable? I think we
I
heard
think
that
so.
it is.
Yep, I think so. And we may even be able to, as I've been looking at it more today, as we've been talking, may be able to figure out a way to keep it in the existing paragraph with a little bit of wordsmithing, but if not, keep it in the same sort of subsection. That was what my original suggestion would have been. But I'll talk with the revisor's office, and I think we can make a change that would be meet their drafting standards and meet the intent of Mr. Garrity and the committee's motion. So.
Okay, great. So we have a motion and a second. And is there any further committee conversation? All right, seeing none, I think we're ready for the vote. So I'll have the clerk call the roll.
Hi, this is Mary Ann. I just stepped away for a moment. All right.
Thanks, Mary Ann. Go ahead.
Senator Sanborn?
Yes.
Senator Sanborn, yes. Senator Brenner? Senator Brenner absent. Senator Stewart?
Yes.
Senator Stewart, yes. Representative Tepler?
Yes.
Representative Tepler, yes. Representative R. Ford?
Yes.
Representative R. Ford, yes. Representative Blyer? Representative Blyer absent. Representative Brooks?
Yes.
Representative Brooks, yes. Representative Connor? Representative Connor absent. Representative Evans?
Yes.
Representative Evans, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Melanargo?
Yes.
Representative Melanargo, yes. Representative Morris?
Yes.
Representative Morris, yes. Representative Quint? Representative Quint absent. 9 members voting yay. 4 members absent.
Great. Thank you very much. Representative Blyer, you have your hand up. Are you back? And did you want to record a vote?
Yes, I did. I'm sorry, Madam Chair. I had to step out for a minute, but it recorded my vote as yes.
Very good.
Wonderful.
Thank you. Representative Blyer,
Thank
yes.
you. And we, just to update folks, my understanding is that this year, if you do come back in the same day and you're able to turn your video on, then you can vote on anything that has been voted on that day in order to help us not have to go back to our presiding officers quite as often and to simplify the process. So if Senator Brenner or Representative Quint or whomever comes back later, we can try and remember to circle back and ask them for their votes on anything that they missed. Representative Brooks, go ahead.
Just a question going forward. Is that a time specific, like with work sessions, it's a little bit variable. Is that till like 4 o'clock or till the work session's over, just to clarify? Or does that have to be clarified?
It's while we're still in the same meeting. So that's my understanding. Colleen, is that your understanding?
I think so. As long as, the committee's still on YouTube and meeting, if you come back before we break for good that day and you can be on the screen and vote. I think that's what we're talking about.
Yeah, that makes sense.
Nobody's informed us clerks about that yet, so we'll have to check with the legislative information to get clarification.
Yeah.
Okay.
Thank
Yeah,
you.
that was something I learned from Sue Panett in Judiciary. So.
Yeah. All right. Well, I will
Okay.
certainly check with legislative information.
Great.
Thank you.
Thank you. All right. Okay. So, Senator Brenner is back. Did you vote on that last motion, Senator Brenner?
No, I have not voted. I'm sorry. I'll register my vote with the clerk.
Okay, great. So moving on, we're on LD 1836, and it is an act to amend Maine's financial institution merger statutes and modernize certain sections of Title 9B. And I'll ask Colleen to present her bill analysis.
Okay. So I'll do this one really quickly since you only had one person testify in favor, which was Bureau of Financial Institutions, although you did have written testimony submitted in support by the Bankers Association and the Maine Credit Union League. This is a department bill. It was submitted by the Bureau of Insurance to make some amendments to Title IX-B to modernize sections of the statute related to update the merger statutes and modernize other sections. Section 1 clarifies the Superintendent of Financial Institutions' authority to employ experts and professionals from other banking agencies or from the private sector as the need arises. Sections 2 and 3 of the bill raise the minimum capital required to establish a financial institution from $100,000 to $500,000. I think the testimony noted it was last. The current standard was put in place in 1975. So just because of the passage of time, they wanted to update that minimum level. Sections 4 and 9 of the bill clarify that a financial institution's main charter terminates automatically if it merges or combines with another institution and the other institution is the surviving entity. Sections 5, 7, and 8 of the bill clarify that a financial institution need not provide notice and have a meeting of investors or decision makers when those investors and decision makers are able to provide unanimous consent for a proposed corporate activity. Section 6 clarifies the process for certifying approval of a merger or consolidation plan. It allows the president and vice president of a bank to certify the adopted plan and provide evidence of that approval to its investors and mutual voters. And then Section 10 replaces the U.S. Treasury target rate used for calculation of interest with a substantially equivalent rate. The rate that's currently cited in statute has not been published in many years, so that needed to be updated. The only thing really I would note with this bill is whether or not the committee is interested in adding an emergency preamble and an emergency clause to the bill. It was not something that the Bureau of Financial Institutions suggested when the bill was drafted, but if you were amenable, it would take effect 90 days following adjournment of the session. Otherwise, if it was an emergency was added, as we've discussed before, it would become effective upon signature by the governor. We don't yet have the fiscal information from OFPR, but again, because this is a department bill, I would anticipate that any additional costs can be absorbed within their existing budget.
Okay, is there any discussion or questions for Colleen? All right, not seeing any, I will entertain a motion. Representative Senator Stewart, go ahead.
Thanks, Madam Chair. I guess it would be helpful to know in regards to the emergency preamble, whether or not the department has any need for it or if it's unnecessary. I'm indifferent.
Okay.
I guess. I don't care either way, but would like to hear from them if that's possible.
Sure. So I'll bring in Mr. Larondo.
Yes.
Good afternoon, Mr. Larondo. Go ahead.
Good afternoon. Answering Senator Stewart's question, an emergency preamble is not something we considered when drafting the legislation, but it's something that we would support if the committee decides to move ahead with it.
Okay, thank you.
With that, Madam Chair, if you'd like, I'm happy to make a motion.
Great, go ahead.
Okay, I would move ought to pass as amended and include an emergency preamble into the bill.
Okay, and I see Representative Tepler has her hand up for a second. I did just send Mr. Larondo back through the wormhole without telling him, so hopefully he made the trip okay. All right, so we have a motion and a second. Is there further discussion with regard to this bill? All right, seeing none, we can ask the clerk to call the roll.
Thank you. Senator Sanborn?
Yes.
Senator Sanborn, yes. Senator Brenner?
Yes.
Senator Brenner, yes. Senator Stewart?
Yes.
Senator Stewart, yes. Representative Tepler?
Yes.
Representative Tepler, yes. Representative Alford,
Yes.
Representative Alford, yes. Representative Blyer,
Yes.
Representative Blyer, yes. Representative Brooks,
Yes.
Representative Brooks, yes. Representative Connor, Representative Connor, absent. Representative Evans,
Yes.
Representative Evans, yes. Representative Matheson,
Yes.
Representative Matheson, yes. Representative Malinado,
Yes.
Representative Malinado, yes. Representative Morris,
Yes.
Representative Morris, yes. Representative Quinn, Representative Quinn, absent. 11 yay and 2 absent.
Great, thank you. All right, I think that concludes our work, although it occurs to me as we're sitting here with the indulgence of the committee that we forgot to bring up the issue of whether LD 1815 should have an emergency preamble. Colleen brought it up, but then when we were talking about the motion, we did not talk about it one way or another. There was a concern from Unum that the bill needs, or that the law needs to go into effect on September 1st in order for us to have continuous regulatory authority, which is likely to be after the effective date in all likelihood, but there have been times where the adjournment date isn't what is expected. So I just bring that up in case we want to do some cleanup on this. We'd need to have another motion, but we could revisit it if that was the desire of the committee. Because I think we did just forget to deal with it. Representative Tepler.
Can we just revisit it at language review, and if we're comfortable at it at that point?
Colleen, what do you think?
Yeah, I think you could reconsider at any time. You can do it now, or you could do it at language review, whatever you'd like. I can bring it back for language review to include it, and then you could reconsider then, or you could do it right now when everyone's here.
It would have to be a motion for reconsideration though, because it's a substantive change.
Either now or then. Yeah, either way.
I'm happy to make that motion if you would like, Madam Chair.
Okay. So yeah, why don't we do that? Because I think we'd love to be able to just do language review on this one without having to spend a lot of time on it.
Okay.
While we're still here. Okay.
Having voted on the prevailing side, I request that the committee reconsider our vote ought to pass as amended for LD 1815.
Okay, is there a second? Seconded by Senator Stewart. And this is a procedural vote where we would all just show our hands in the window physically. And I see Senator Stewart, is your hand up? I see everyone's hand in the window. So it would be unanimous of those present to proceed with a motion for reconsideration. So Representative Tepler, do you want to make another motion?
Sure. I move that we add an emergency preamble to LD 1815 with adding it to the ought to pass as amended vote.
Okay. And I see a second from Representative Matheson. And I will ask the clerk to call the roll.
Thank you. Representative Sanborn?
Yes.
Representative Brenner?
Yes.
Representative Stewart?
Yes.
Representative Tepler?
Yes.
Representative Alford?
Yes.
Representative Blair?
Yes.
Representative Brooks?
Yes.
Representative Connor? Representative Connor, absent. Representative Evans?
Yes.
Representative Evans, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Malinano,
Yes.
Representative Malinano, yes. Representative Morris,
Yes.
Representative Morris, yes. Representative Quinn, Representative Quinn, absent. 11 yes, 2 absent.
Okay, thank you, committee, for allowing me to catch my mistake there with regard to that issue. And that does conclude our work for the day. As I mentioned a couple times, our intention is to have some work sessions on Tuesday. I don't think it'll be a full day of work on Tuesday because I don't think we actually have that many work sessions, but Colleen and Representative Tepler and I will be figuring that out, and there will be a notice by tomorrow with regard to what our plan is for Tuesday. So with that, we have concluded our work for today and we'll adjourn. Thanks, everybody.
Thank you.
Colleen, do you want to send us a link so we can do
Yeah.
some scheduling?
That'd be great.
Okay,
I'll send
thank
it to you right now. Super,
That
thanks.
would be
Okay.
helpful because I'm not available tomorrow. I have
Okay.
the maternal child health meeting virtually.
Great, I'll do it right now.
Thanks.
Yeah, thanks, bye.
Bye.